So, buongiorno, good morning, everyone, and welcome to this first session of the last days of the terrific meeting. We'll discuss something that takes so much of our practice, the management of patients with multivessel disease in the modern era. And in the interest of time, let's start with our first speaker. Miguel Sousa Uva is the chairman of the guideline of the European Society of Myocardial Revascularization and will give us the details of the recently published guideline. Miguel.
Thank you very much. I'm very honored to be here as the co-chairman of these joint guidelines between ESC and the European Association of Cardiothoracic Surgery. I have no disclosure. So this was a large group of individuals from interventional cardiology, clinical cardiology, and cardiac surgery from the two associations. And my co-chairman, Franz Josef Neumann, was here yesterday. And I was asked to talk about the guidelines on the setting of multivessel disease, modern management. Well, first of all, I would like to start with our recommendations on decision-making. This is, you see that all of recommendations regarding patient information and decision-maker are class 1 level C. Of course, level C, there are no randomized trials. This is expert opinion. So the patient should be informed about the benefits and risks ahead of the coronary angiography. Before the angiography, the three possibilities: medical therapy, PCI, or CABG. So it is recommended also that the patient be informed about the short and long-term benefits and risks of the revascularization procedure with information about local experience and allowed enough time for informed decision-making. Therefore, ad hoc PCI should be performed within the institutional heart team protocols, which have to be made. I don't know if this is followed. I would be very interested to see if in the real world what is the incidence of real institutional protocols in the various institutions across Europe. And in PCI centers without on-site surgery, it is recommended that institutional protocols are established with partner institutions providing cardiac surgery. So, starting with the criteria for the choice between CABG and PCI in multivessel coronary disease, there are four main aspects to be considered. First, the anatomical complexity of the disease. Second, the surgical risk. Third, the presence of diabetes. And fourth, the completeness of revascularization. So, starting with the anatomical complexity of the disease, we recommend in these guidelines, again, that the syntax score be calculated. We know the limitations. We learned yesterday, of course, there are limitations, but it's the best we have. It's better than to say it's a three-vessel disease, and therefore it helps a lot. It helps clinicians, it helps patients knowing what is the complexity of the disease because it has a prognostic impact in those patients that undergo PCI, contrary to those who are undergoing CABG. So it's easily accessible on the webs. Also, so therefore, assessment of coronary artery disease complexity, syntax score is recommended to be calculated, and also the assessment of surgical risk. And the STS score gets a class 1B recommendation, while the Aero score 2 is a 2BB recommendation. This is the recommendations, and I'm concentrating on stable coronary artery disease, since there is a presentation by Stuart Head later on acute coronary syndromes. This applies to patients with stable coronary disease and low operative risk. And this we wanted to show by inserting this table on the guidelines, what were the mean Euroscore on the populations of the main trials of multivessel disease. The last two are trials for left main, as you know. So this is what we consider the recommendations, the mean risk of surgical risk of those patients included on those trials, since the recommendations, of course, and this is one of the limitations of guidelines, must have the characteristics similar to those that were included in these large randomized trials comparing PCI and CABG. So the second, I would say the third element to be considered in the choice between PCI and CABG is the completeness of revascularization. And one of the main pieces of evidence upon which we based is this recommendation is this large meta-analysis where you see that for CABG, for PCI, and also using different definitions of completeness of revascularization, you see there is a clear benefit of complete revascularization. Our recommendations were deeply influenced by this patient-level meta-analysis, including 11 randomized trials and 11,500 patients, published by Head in Lancet in February this year. In the overall population of these 11 randomized trials that compare CABG with PCI, there was a significant survival benefit. This is the mortality rate here, in red PCI, in blue CABG, and the separation in the two populations. So we are considering here, in this setting, this is a highly significant benefit of CABG versus PCI, and I must stress that these were trials where patients were included by the heart team, so they had to be acceptable surgical risk and an anatomical complexity that was accessible to PCI. The subgroup analysis showed here overall population, where you have a hazard ratio that does not cross 1, so favoring CABG. And then on the multivessel population that we are talking this morning, you have a P4 trend which is highly significant, and you see that in the subcategories of syntax trial above 23, it clearly favors mortality for the first time. This is the first time ever that we have specific information on mortality, since the individual trials were not powered to address and were based on composite endpoints. Regarding diabetes, we are all aware of the FREEDOM trial. I just brought this slide to remind you the main endpoint of FREEDOM trial, where the main endpoint was death stroke MI, 18.7 versus 26.6, which is very similar to the three vessel diseases subpopulation, and even death, which achieved statistical significance, and also the results very similar to what was achieved in the syntax. Of course, the stents were not second generation drug-eluting stents, and this is the same old problem of a continuing evolution of technologies, and you have to have follow-up. Going back to the individual patient meta-analysis published by Stuart Head in The Lancet in 2018, you see that there was no difference in the non-diabetic patients, where in the diabetic patients you have a highly significant benefit in mortality with CABG with 10.7 and PCI 15.7%. This was a mean follow-up of about 3.8 years. So therefore, the recommendations are summarized here. And the separated, and we brought the diabetic chapter into the stable coronary artery disease. Therefore, three vessel disease separated according without diabetes. And in patients with syntax up to 22, it's a class 1A for both methods, whereas in patients with intermediate or high syntax score, it's a 1A and a 3. And in patients with diabetes, you have for PCI a class 2B for low syntax score, once again in patients with suitable coronary anatomy for both procedures and low surgical mortality. Of course, besides this characteristic, besides complex anatomical complexity, the presence of diabetes, the expected completeness of revascularization, there are other characteristics that favor either PCI or CABG, and we have summarized them here. I will not go through it, but you can see that, for example, if you have sequelae of chest radiation, post-Lane aorta, although this means that you can do an off-pump aortic no-touch technique, but these are advanced age, frailty, reduced life expectancy. Of course, all these are characteristics that favor PCI, whereas others favor CABG, like reduced ejection fraction, and problems with double antiplatelet therapy or recurrent diffuse instant restenosis, and there are others, of course, as concomitant surgery. And we have summarized in an accompanying paper, Stefan Windecker is the first author in the European Heart Journal, the rationale behind our decisions for these guidelines. And on the left side, you can see summarizing nicely what we have recommended. I will not go through the technical aspects of CABG, which are summarized in this figure. Just to finalize, we added at the end of this document evidence-based to do and not to do, which are the class 1 and class 3 recommendations. And I just brought one for your attention in patients with non-stable, non-STEMI acute coronary syndromes. You know that many of these patients are simple rises in troponin. And these patients, there is now evidence, observational evidence for large registries, namely one from British Columbia in Canada, that shows that it is recommended, and therefore from this we derive this recommendation, it is recommended that revascularization strategy should be based on the patient's clinical status, comorbidities, disease severity, and according to the principles of stable coronary disease, meaning that once these patients are stabilized, the same principle should apply. So what's new in relation with CABG? So as I told you, in stabilized non-STEMI patients, the same strategy as for SCAD. In low ejection fraction in patients with heart failure, PCI is an alternative in 3-vessel disease, but this should be discussed within the heart team. And as the completeness of revascularization prioritized, no touch vein technique if open vein harvesting for CABG, and the downgrading in PCI for multivessel disease with diabetes and syntax score below 23. So these guidelines are available online for everybody to download, so I welcome you to have them accessible. Thank you very much.
Thank you, Miguel. Well, in the interest of time, I think we can have a question at the end. So now we will ask Filippo Crea to give us the wise perspective of the clinical cardiologist. Do we revascularize too much?
Well, it is a great honor to be here among so many distinguished cardiac surgeons. And I feel a bit like Jesus Christ among Romans discussing medical treatment in this setting, predicating a funny religion. But medical treatment is important. In the past few decades, we have witnessed a remarkable reduction in death from cardiovascular diseases. And as shown in this very elegant epidemiological study, 60% of this reduction is explained by risk factor control. 40% only is explained by treatment, including drugs and intervention. So medical treatment definitely is important. And also after revascularization is important. This is a post-hoc analysis of the syntax, and you can see that optimal medical treatment, antiplatelet, statins, beta blockers, and ACE inhibitors, was given to about 50% of the patients after discharge, even less after surgery as compared to PCI. So only 50% of patients had the best possible medical treatment, and at 5-year follow-up, same figures. And this is a missed opportunity because patients not on optimal medical treatment had the worst outcome compared to patients on optimal medical treatment. Pills for life is a bit boring. It's more spectacular to receive stents or bypass, but they work. And after revascularization, it is important to keep these patients on a good medical treatment. I would like to focus now briefly in these two large subsets of patients. Well, basically, to make complex things a bit simpler, we deal with patients who are at high risk a large area at risk of ischemia, left mainstem disease or severe three-vessel disease. And then we have patients at low, medium risk, small to moderate area at risk of ischemia. Well, if we focus on patients at high risk, there's no doubt that revascularization works better than medical treatment, and surgery in particular. This is the case study 30 years ago. Please look at the numbers. A total of a bit more than 100 patients randomized to surgery or medical treatment, and was enough to have 100 patients 30 years ago to definitely demonstrate that in patients with mainstem disease, surgery is better than medical treatment. After 30 years, we have this very elegant meta-analysis, very well discussed before by the previous speaker. But I'm, let's say, simple-minded. My reading of this study is very straightforward. In this meta-analysis, surgery with regard to mortality worked better than PCI. Then, when we go to subset analysis, the only interaction, significant interaction between treatment and subgroups was for diabetes. Definitely, as well clarified before, surgery worked much better in diabetic patients. But subset analysis, we know, is hypothesis generating. And then when we come to the interaction between syntax score and treatment, well, the ocular reflex would say there is an interaction. You can see here. The eye says there is an interaction, but the mind denies this interaction because P4 interaction was not significant. And the same was true for the interaction between treatment and mainstem versus three-vessel disease. Again, in this case, the interaction was not significant. And when we come to diabetes, I think there is really good evidence that surgery works better. This is a pooled analysis of 3 studies, VARI2D, coverage, and freedom, different endpoints, composite and MI, and CABG versus PCI, CABG works better, CABG versus medical treatment, CABG works better. No difference between medical treatment and diabetes. Of course, patients in trials are different of patients in real life. On average, the outcome of patients in trials is better than that of patients in real life. Conduit, past president of the ACC, once told me, well, if I come to your hospital with a heart attack, please put him in a trial because the outcome is better. And when we come to the complexity of our daily patients, again, as clearly pointed out by the previous speaker, the heart team is important. But in order to work, the heart team has to be a daily activity, cannot be done once in a week or once in a month. And it is here that we discuss complex patients. And in the heart team discussion, in my experience, the decision between surgery and PCI is made mainly based on life expectancy, comorbidities, angiographic disease extent, and also, last but not least, perceived need for and technical likelihood of complete revascularization. Is an integrated analysis of this complexity which eventually leads to the best solution. And that the heart team is important, a daily heart team. And in our institution, as you will see later, we have a daily heart team. This is a very simple study, 200 patients, and the agreement among cardiac surgeon, cardiologist, and heart team was 70%, which means that in 1 out of 3 patients, the decision of the heart team changes the attitude towards that particular patient. When we come to patients at low, medium risk, well, here the choice more than between surgery and PCI is between PCI and medical treatment. And as you know, there are different trials comparing PCI versus optimal medical treatment in stable patients at low to intermediate risk. Please note that these are patients at low to intermediate risk. These are the entry criteria of the coverage trial, one of the most quoted trials in this setting. And you can see that exclusion criteria were severe angina, a markedly positive stress test, refractory heart failure, and a low ejection fraction, and of course, left main stem disease. So in all these trials, patients were at low to medium risk. What about comparison between PCI and medical treatment? This is one of the many meta-analyses, not the last one. The last one has been published 2 weeks ago, but the results do not change. And you can see that in this meta-analysis and in other similar meta-analyses, patients with evidence of ischemia randomized to stenting versus medical treatment, well, difference is nothing. No difference in death, no difference in fatal MI, no difference in unplanned revascularization, including FEM2, no difference in, no difference in persistent angina. And this is very intriguing. Okay, PCI in this patient population doesn't improve the outcome, but what about angina? Angina should definitely be better after revascularization. Well, this is not the case. This is the coverage trial, and angina-free in 20% of patients prior to revascularization, prior to randomization, and after randomization, angina-free patients, the proportion was higher. But you see, angina-free patients were 50% of the whole population, not 100% or 90%, just 50%, and no significant difference after 3 years between PCI and medical treatment. So why persistent angina in 20 to 40% of patients after PCI? This is a cartoon from a recent review article I've published in Circulation with Juan Carlos Caschi, Bernie Gersh, and Paolo Camici. And here we highlight the notion that ischemia not only is caused by thrombus and by epicardial stenosis, but can also be caused by functional alterations, which for many years have been underlooked. And functional alteration can be epicardial spasm or can be microvascular dysfunction. And when we come to recurrent or persistent angina after revascularization, after PCI in particular, we can have structural causes, instead of stenosis or thrombosis, progression of disease, incomplete revascularization, diffuse disease, presence of myocardial bridges. But we can also have functional causes, as I told you, including spasm and microvascular dysfunction. And these functional causes explain about 50% of persistence of angina after PCI. This is a study which will be published in a couple of months in the European Heart Journal, where we review this important topic of persistence of angina after PCI, and propose a diagnostic algorithm for patients presenting with persistent angina after PCI, which allows to explore this algorithm both structural and functional causes of persistent angina. And last but not least, the growing complexity of our patients. These are data from the Mayo Clinic. You can see period 91-96, mortality after PCI, cardiac mortality was much more frequent than non-cardiac mortality. 97, 2002, well, in this period, mortality for cardiac and non-cardiac causes was similar. 2003, 2008, non-cardiac mortality was much more frequent than cardiac mortality, totally reversed. Well, this is a signal that our patients are becoming more and more complex, and we cannot focus any longer just on coronary circulation, but we have to assess patients in their complexity. And these are my very simple concluding remarks. In high-risk patients, CABG is the best form of revascularization to improve heart outcome. I think that this is beyond doubt. PCI is a reasonable alternative to CABG, so CABG is the default choice, but PCI is a reasonable alternative to CABG in patients at high surgical risk, the key role of the heart team. These patients have to be discussed daily in the heart team in order to establish what is the best option. In low-risk patients, PCI is a reasonable alternative to anti-anginal medical treatment in patients with persistent symptoms, but further studies are warranted to establish the role of coronary microvascular dysfunction in this setting. Of course, the importance of drugs and prevention. All patients need optimal medical treatment after revascularization to improve the outcome. And this is not always the case, as we have seen in the post-hoc analysis of the SYNTAX trial. Patients and perhaps doctors feel protected by stents and bypass, but this is not the case. After revascularization, treatment is remarkably important. And last but not least, the impact of non-cardiac mortality deserves growing attention. Again, the ideal setting is the heart team, because patients we are dealing with are more and more older, more and more complex. Surgical risk is high in many of these patients, and the balanced view we can only have in the heart team is the best premise for an optimal treatment. Thank you.
Thank you, Dr. Crea. Are there any comments from any of the panelists? Miguel, please. Can we have the mic on, please?
Number 5.
Hello? Oh, yeah, thank you. Yes, I enjoyed very much your presentation, and it's key in a session like this, where we all focus on revascularization, and we forget the modifiable risk factors, lifestyle, for example, obesity, and exercise, and medical therapy. But I wanted to ask you one question that I think it's important, and you stressed in your conclusion. I would like you to elaborate a little bit more on the non-cardiac mortality issue. Because what is your opinion about the fact, we know, for example, that in the ticagrelor study versus clopidogrel, there was an improvement in mortality in the subgroup analysis of the Plato that showed that patients on the ticagrelor group with aspirin versus the clopidogrel had lower non-cardiac mortality. And there are hypotheses maybe related to, for example, infectious causes related to clopidogrel. And now we have, for example, the EACTS trial at 4 years that is stressing on the fact that increased mortality after PCI of the left main is related, okay, there is increased mortality, but this is a non-cardiac mortality. I would like to have your opinion on that. Thank you.
Yeah, and going to another field, TAVI is another good example. Well, the problem is that we are dealing with patients who are older and older and more complex and more complex, which means that other diseases compete with cardiac disease to determine mortality. So I think that first we have to consider futility of our interventions. Patients already at high risk for other conditions before revascularization shouldn't be revascularized. And again, the heart team is the ideal setting to discuss these complex patients. The second implication is that after revascularization, we have to follow these patients as patients, not as coronary patients. This is the complexity of medicine. You know, the problem with medicine is that we are getting more and more subspecialties, which is unavoidable because treatments are so complex that we need subspecialists. But after this fragmentation, it's important that all subspecialists meet together around the patient. And again, their team and their team philosophy and their team approach, which means integration around the patient, is the way to go, in my opinion.
Thank you. Can I, while Miguel is here, Dr. Crea and Dr. Uva gave what I thought were excellent overviews of current treatment. But what I would like you to specifically address is the Stuart Head meta-analysis, and Stuart's going to be here later today, because I think it's a dangerous meta-analysis the way it was presented. And I say that because the vast majority of the patients on which that analysis was based were very low-risk patients. With the exception of the syntax trial, if you look at every other individual trial within that meta-analysis, the mean syntax score was 22 to 24. So what I would argue is Stuart's paper should have been presented as CABG is better than PCI even in low-risk patients. So now the EACTS trial, for instance, argued as the most important trial of PCI versus CABG in left main, nobody mentions the fact that these were patients with syntax scores below 32. So we have to be very careful and emphasize, and I felt that in the abstract of Stuart's paper, it should have said in selected patients with coronary disease. Because what it actually shows is that even in these largely low-risk patients, CABG has a clear survival advantage. And if you looked in the real world, the magnitude of that survival would be much greater. So I would like that we have Dr. Crea and Dr. Uva to hear their views.
Well, I told you what my friend told me. If I come to your hospital, please put me in a trial because the outcome is better. So definitely, there is, what we see in trials is different from real life. And I think the implications are very clear. If the patient we have in front of us is the average patient in a trial, and this is a minority, well, then we can easily apply what is found in the trial. If the patient doesn't stick to those inclusion and exclusion criteria, hard team. You know, the hard team is in guidelines, is in textbooks, is not in real life. We should make an effort to make the hard team a live creature. We succeeded in our institutions. If we succeeded, I don't see why others cannot succeed. But I know that we are the exception.
Thank you. Miguel, do you?
Yeah. No, it's not. Is it? Yeah.
Yeah.
Okay. Yes, David, I completely agree with you that you mentioned, but that's what we have. We have to base our recommendations on the best available evidence. However, as you say, the devil is in the details, and how you write the conclusions, how you write your abstract, how you write the discussion of the paper. And it's indeed very well known, and you have stressed this when you address the STS some years ago, in a paper that was then published in the Annals, that the percentage of patients that are finally included in the trials is around 5 to 10% of the patients that were screened. So this is a highly selected population, and we know that this sometimes is forgotten when we are talking about those trials and the lessons that derive from those trials. Therefore, it is true that it is, we must be careful when extending this to a real-life setting to well know the exclusion and inclusion criteria. And for example, for the EACTS trial, it's very instructive to go to the New England supplement. It's more than 200 pages of supplements. And just look at the exclusion criteria. For example, despite the fact that these were very highly tertiary centers, The anatomical exclusion criteria you need to have equipoise between the cardiac surgeon and the interventional cardiologist, and there are a lot of exclusions, and therefore, when interpreting the results of the trials, you have to look at the inclusion and the exclusion criteria.
Thank you.
Thank you.
Thank you, Miguel. So let's move to the next presentation. Olivier Bertrand for Laval will discuss the new advance in PCI.
Good morning, everybody. And like Filippo, I'm very honored and humbled to be invited to such a distinguished cardiac surgeons meeting. So I'm going to try to make some entertaining discussion here. And obviously, I'm going to start by acknowledging that I'm deeply biased, since I'm going to discuss the radial artery and the radial access site. And as a first topic, and a second topic will be physiology, and how maybe cardiologists are basically, by essence, reluctant to change. I don't know about cardiac surgeons, but I can tell you, and you're going to see in a minute, about cardiologists. So we have known that for years, that sometimes when you use the femoral artery, I mean, you are facing dreadful complications like this retroperitoneal hematoma or pseudoaneurysm. And of course, many cardiologists were continuously claiming that that does not happen in their practice, also because in the US you have physician assistant that do the job of managing the access site. So this is something that we want to avoid, but in fact we were a little bit like Mac user in the PC world, and radialists were not very heard of. So the second issue was, for many, many years, or for the time being, we were like this poor guy trying to get money to do alcohol research. I mean, that was the same thing for doing radial versus femoral trials. There was no incentive from any industry, medication or devices to conduct trials. So it was only a matter of enthusiast people trying to promote the patient-centric approach of the radial approach. Fortunately, our cardiologists came to realize the importance of bleeding, which was separated into access site bleeding and non-access site bleeding. And as you see here, there was a clear relationship between not only access site related bleeding, but also non-access site bleeding on 1 year mortality. So this was something huge, and this was something which was obviously found at the time of widely used 2B3A inhibitors. So how bleeding can impact mortality or outcomes, obviously may be directly when you have a cerebral hemorrhage, of course, or retroperitoneal bleeding that get unnoticed, or also secondary effect or indirect effect when you stop the medication or you use transfusion, and then you get stent thrombosis because of the interruption of the antiplatelet therapy. So Europeans have been leading the way for many, many years. I mean, I just want to remind you that the first diagnostic radial cath was performed in Canada in 1985, published in 1989, and the first radial PCI was performed in the Netherlands by Dr. Kimene in 1992. Europeans have been adopting and treating their leaders, I would say, a different way. As you see here, Sarkozy getting his diagnostic cath by radial, whereas Dick Cheney is in poor shape. As you know, he has used anything which has been invented in cardiology since that period of time. But let's say that people have been publishing. We have tried to do meta-analysis. I remember that in 2010, I spent almost 2 years trying to get a meta-analysis involving more than 1 million patients, which was rejected many times, saying that it was low priority. But finally, when you look at all those studies involving thousands of patients, there were two very large trials in 2012, the Rival and Matrix, performed in Italy, showing benefits in terms of death, MACE, but especially due to reduction in bleeding and cardiovascular complication. This has been constant since the beginning of the radial approach description. So in summary, that was the impact. Significant reduction in whole-cause death. That was something that was observed in primary PCI that led also some change in the guidelines. Reduction in MACE, impact on major bleeding, as I said, and vascular complications. So finally, when you see now after the evidence-based data, you see the change in practice, and the BCI's group in UK and Jim Nolan and Mamas have been very active to show, for example, the change in the radial adoption in UK from 2010 to 2014, and you see there is wide variation. I think now they can identify the remaining femoralists in the country. I mean, there are about 10. And they looked at the impact of cost, which is obviously where everybody is looking for funding. And you see that there is huge impact of cost. Cardiologists have been very also successful in the UK by having insurances now providing financial incentive when you use radial, which is, of course, always a good way to convert a cardiologist. So as you see, in 2005, there was no mention of radial or transradial in the guidelines. We tried everything we could. There was nobody to listen to us. I mean, there was a few mentions in 2010, and finally in 2018, we got this clear recommendation to use radial access with a word of caution, which I don't even understand myself. So the next step as cardiac surgeons, we did this paper with the leadership of Mario, published quite recently in JACC, trying to summarize the benefit and the indication to use basically radial access in every case. But maybe also we have to now think that the radial artery may also have a very important role on the long-term benefit of cardiac surgery. Of course, we don't want to set back and remove the use of the access, but maybe we should also take that into the equation and again have a patient-centric approach. Let's move now to the second topic, and which is discussing physiology. Physiology is also clearly recommended in the guidelines, and I'm going to show you how bad, in fact, cardiologists have been using physiology and basically relying on the oculostenotic reflex to decide upon revascularization on PCI. So these are data, industry data from Philips, as you see that despite also more than 20 years of physiology studies, the use in clinical practice is basically extremely poor and mostly less than 5% in the world. Canada has been doing quite well though. And this is really, as you see, I mean, this slide summarizes everything, and there are many, many studies like this. When you try to guess, and again, I mean, cardiologists will claim that they are very good to know how the physiology of the artery or the lesion is, and in fact, we are dead wrong. You see that even for a moderate lesion, quite a significant lesion are basically physiologically significant. On the other hand, and that comes also to the benefit of the medical therapy, many so-called very severe lesions are, in fact, non-physiologically significant. So very rapidly, I don't want to go into too much details for data, but we had this comparison in more than 1,000 patients comparing the eye and the physiology, and you see again in clear benefit of using physiology instead of your eye. And second, FAME2 just reported recently the 5 years follow-up, and you see that the terms of comparing medical therapy versus FFR-based PCI, you have a clear benefit of using physiology to guide your intervention. And this is not really in terms of death, again, up to 5 years, but there is a benefit in the combined myocardial infarction rate, or especially the rate of urgent revascularization. So this is interesting data from a French group. There are many trials like this. Oh, not, I shouldn't say trials, but studies, observational studies. And on the left side, you see how often when cardiologists do the angiogram and refer the patient based on the angiographic findings, either for medical therapy, PCI, or CABG, well, basically, when they do the physiology and the FFR assessment, they change their mind based on the results. And you see on the right side that this applied for the medical so-called group, PCI, or even CABG, although, as you see, CABG number of patients is extremely limited. But almost in 30 or 48% of the cases, you're going to basically refer patients for medical therapy instead of revascularization. So we are wrong in many cases. There is a new kid on the block, still much discussed, but besides the hyperemic index of using FFR, which is obviously, as you know, the comparison between the distal pressure to the proximal pressure when you induced maximal vasodilation, I mean, you can use so-called IFR or the basic PDPA, and you basically up to 1 year in 2 very large trials recently reported in the New England Journal of Medicine, reported non-inferior results. So there is a big push now from the industry in particular to promote dose resting index. There are still some discussion because especially for cardiac death, there is some kind of trend of higher cardiac death in the IFR, but overall it was a non-inferior, it was 2 non-inferior trials which were quite showing impressive results. As cardiac surgeons will be interested maybe to look at some of the results. This is FIM3 trial, it's still underway, so patients with 3-vessel disease are basically randomized after heart team discussion for lesions between an FFR-guided PCI of lesions which are obviously physiologically significant based on FIM2 trials, or to perform CABG based on the angiogram, which is the routine practice, and you also can use FFR in that group, although it is probably not not done very often. The follow-up the primary is at 1 year, but I've just discussed with Bill Fearon that there will be follow-up up to 5 years. So that's going to be coming in probably next year. They have randomized already 1,200 patients, and they hope to reach 1,500 very soon. So my last topic will be the use of physiology after. In fact, the inventor of PCI, Grunsick, was already thinking that we should measure something after using balloon. It was not very popular at the time, and let me just show you one example. So this is an 83-year-old patient. You see that there was a lesion on the circummarginal branch, and there is a lesion on the LAD. There is a severe lesion, as you see here. There is a moderate lesion on diagonal, but there is severe lesion on the LAD. So we do the FFR on the circ. It's not repeat imaging, but as you see here, in fact, it was angiographically severe lesion, but the FFR was negative, so I didn't treat the lesion, obviously. And then the FFR for the LAD was very physiologically significant, 0.47. So I did stenting. And by curiosity at the time, I remeasured the physiology afterwards. And you will agree with me that in terms of angiographic result, it's perfect. I mean, there is a slightly overexpansion, there is no dissection. And when you measure, in fact, the FFR is only 84. So I was interested at the time to look at the literature, and you see that physicians have been collecting data of post-PCI FFR for a long time. There is wide variation, there is no improvement over time. But we were quite impressed to see that there is a relationship between the post-PCI FFR and outcomes, either in terms of risk of repeat revascularization, and of course, the higher, the better. There was some cutoff about 0.90, but the principle is to see that the higher is the better. And there is also a relationship with MACE. So one thing that will complement what just Filippo was showing, you see, this is a study when cardiologists were interested to compare the so-called biodegradable stent or scaffold to a state-of-the-art stent. And I would just be very briefly, when you look at the result, and of course they were interested to show, to try to show at least in this trial the superiority of the polymer-based stents, which, as you know, later on failed. But it's quite impressed that for those patients with very simple 1 or 2 lesions in a controlled environment of a randomized trial, core-lab assessment, that you can see that still 20% of patients remain with angina at 6 months and at 1 year. So, I mean, you can be sure that the angiographic results were perfect, simple lesions, but still in a significant number of patients we fail. And this, we fail in terms of symptoms, but this was also correlated with the result of the objective evidence of ischemia. As you see, in both groups, patients remain with a positive exercise test at 6 months and at 1 year. So why is so? I mean, you have to think that the stenting is a segmental approach of the disease, which is by definition diffuse. And again, we have to integrate that the LAD is probably a different animal than the other vessels. So why we feel after PCI, either we can improve the result at the stenting, this has been shown. We have, as discussed yesterday, the use of intravascular ultrasound or CT to optimize the segmental approach. But we have to acknowledge that when you are facing very diffuse disease, it will be basically impossible to reach the threshold of 0.90 or even identity level. These are the last results I'm going to show you, and they've been presented very recently at the PCR. And this is a very large registry of about 1,000 patients. And you see that using two different cutoffs, again, comparing the LAD with the non-LAD, and you can see that on 1 year, the TVF, target vessel failure rate, is way, way different in patients when you get above the threshold versus below the threshold. And this threshold could be reached in about 2/3 of patients. So in conclusion, it took 25 years after the first radial PCI to show that radial access site is now in the guidelines and clearly recommended as the default access site for diagnostic angiography and PCI. Yet, improvement to reduce the risk of chronic radial artery occlusion by probably knowledge transferred and promote rapid vessel healing after radial artery injury use for repeat access. Many of those patients will have repeat procedures, or later on CABG will be probably paramount and the subject of intense discussion in the next couple of years. The evidence for physiology for pre-revascularization decision-making is overwhelming. But again, physicians don't want to listen. It's still clearly underused. And I believe now, and I'm working a lot on this, that post-PCI physiology will be coming. We have access to much better pressure wire. We have access to fiber optic technology, which is much more reliable, and things will continue to change. Thank you.
Thank you, Dr. Bertrand, for that very clear talk. And we might ask you some questions once about the use of radial artery, because as you acknowledged, it's increasingly important for surgeons to have access to the radial artery. And my own group published a paper in Circulation about 2 years ago showing that once you have catheterized the radial artery, it remains biologically vulnerable for a very minimum of 6 months. So we'll hear Mario's talk on his it's the new evidence for the old story, and then perhaps we could have a brief discussion on how do the cardiologist and surgeon decide how to distribute the radial artery. So, for example, should the cardiologist stick to the right and the surgeon to the left? Mario, please.
Thank you, David. And so my task is to give you a brief overview of the current evidence on the choice of conduits for coronary artery bypass surgery. A pretty old story, as we all know. However, 2018 has been really a great year in this sense, and it's fascinating that this is happening exactly 50 years since the initial description of the operation by René Favaloro. This is the paper that was published in 1970 in the Annals of Thoracic Surgery. It's actually describing a series of patients that were undergoing direct coronary artery reconstruction using a piece of saphenous vein. The last patient of the series, because of technical reason, could not undergo the procedure and instead got what we today call coronary artery bypass operation. And if you look into the details of the study and do a little bit of math, you will realize that that was happening in October of 1968, so exactly 50 years ago. In any case, a few years later, like 3 years later, another paper on the same journal was already asking if the use of arterial grafts was a better option for this operation. So really the debate about the use of conduits in CABG is a 4 decades old story. Well, we all know that there is a large observational evidence that suggests that the use of multiple compared to single arterial graft is associated with longer survival in patients undergoing CABG operation. Recently, we have published this meta-analysis. There have been several, and this one in particular was on 38 study and 150,000 patients. What we found, like many others before us, is that patients receiving 2 arterial grafts compared to 1 had longer survival, and this finding was consistent over the year, and even when adjusted for patient characteristics like age, gender, and comorbidity. However, the interesting finding of this meta-analysis is that when we compared the survival benefit at 1 year after surgery and at the end of the follow-up, well, they were identical. We selected the 1 year time point because biologically we don't expect any difference at 1 year. There may be some small difference in patency rate between arterial and venous conduits, but it's unlikely that they can affect an outcome like survival. So this finding per se suggests that unmatched confounder and treatment allocation bias can be the reason for the difference in survival that we see in most observational studies. To make the story short, observational studies are just not good enough to provide a solid answer to the multiple arterial graft controversy. On the other hand, in May of this year, we published the final result of the 5-year result of the radial artery project. The radial artery project is an international alliance of surgeons interested in the use of the radial artery and was aimed basically at overcoming the power limitation of the individual randomized trial that compared the radial artery and the saphenous vein for CABG, and to perform a patient-level meta-analysis with enough statistical power to evaluate potential difference in clinical outcome. Our primary outcome was in fact a clinical outcome, a major adverse cardiac event composite outcome, and secondary outcome was angiographic patency based on Fitzgibbon classification. We included 6 trials and 1,200 patients. And the main finding was that at the mean follow-up of 5 years, the use of the radial artery was associated with a significant reduction in the risk of the composite outcome of the SMI and the repeat revascularization, and a significantly lower risk of graft occlusion, which provide a mechanistic explanation for the clinical finding. When we look at the individual component of the composite outcome, it's obvious that repeat revascularization is driving the outcome. However, we reach nominally statistically significance for the difference in follow-up MI, and there was a signal also for a difference in death, all in favor of the radial artery. Yesterday, we have listened to David giving us the result of the 10-year result of the ART trial. Just want to remind everyone that ART is actually the largest trial ever performed in cardiac surgery when you adjust the number of patients for the length of the follow-up. The results of ART were given according to 2 different types of analysis, the ITT analysis and the as-treated analysis. This is particularly relevant for ART because of the high rate of crossover from bilateral ITA to single ITA and the frequent use of the radial artery in the single ITA group. Almost 40% of ART did not in fact get the randomized treatment. In the ITT analysis, the ART investigator found no difference in survival and no difference in the composite of the SMI and stroke. However, in the AT analysis, there were a very strong signal in favor of the multiple arterial graft groups, with all the obvious limitation of the non-randomized nature of this comparison. The ART investigator, in fact, acknowledged that the use of the radial artery and the high crossover rate were potential explanation for the neutral finding of the study. Surgeon experience was another very important finding in ART. There was a very clear correlation between surgeon experience and the result of the ITT analysis, we can see in this subgroup analysis comparison. And the highest enroller in ART, the surgeon that enrolled more than 400 patients, are completely different result in favor of the bilateral ITA compared to the result of the main trial. This is something that we have also found using a meta-analytic approach. Here we have performed a meta-analysis looking at all the studies that have compared bilateral and single ITA, and we have found that the 2 most important outcomes of the beta operation, long-term survival and the incidence of deep sternal wound complication, were both significantly affected by surgeon experience. And finally, the last thing that is happening in the conduits world is Roma. Roma is another randomized trial that is looking at the difference in clinical outcome between patients receiving a single or multiple arterial graft. We see Roma like the continuation of art. Roma has been designed, taking into account the lesson that has been learned from art in terms of sample size, in terms of primary outcome. Most importantly, in Roma, there is a freedom to choose the second arterial conduits in the multiple arterial conduits group. It can be either the radial artery or the right internal thoracic artery. This probably provides more flexibility for the surgeon to adapt the strategy to the individual patient, and we believe that we will increase the deliverability of the operation and reduce the crossover rate. And also, we selected a pretty high experience cutoff for participation in the trial. This is how we see the enrollment rate in Roma. So far, Roma has completed the pilot phase, which included 10% of the overall sample size, 430 patients. I like to underline the fact that the sample size was completed in 10 months instead of the 12 months that were initially planned. Here you see the actual enrollment rate during the pilot phase, whereas the other two lines were the planned enrollment rate. There was a more conservative and more liberal estimate, but the actual enrollment rate was also always higher than the one that was expected. So if I have to summarize in few sentences what the status of the knowledge on the use of conduits for coronary artery surgery in 2018, I would say that now we know that retrospective study is just inadequate to provide solid answer to the arterial graft controversy. There is a strong signal in favor of the use of the radial artery and supporting the importance of surgeon experience. Roma will probably provide the answer to this 40-year-old debate, and final results are expected in 2025. So it's a great time to be a coronary surgeon. Thank you for your attention.
Mario, thank you for that very clear overview. So if we could ask yourself and Dr. Bertrand to discuss how do we divide up the radial artery, because you've shown very clear evidence that there now does seem to be an important clinical benefit of the use of radial artery over saphenous vein. So if I could ask Dr. Bertrand, for example, if you have catheterized one radial artery and you need to come back, say, for a few weeks later to either repeat an angiogram or do something else, is it always possible to use the same radial artery, or is it usually occluded, or how do you approach that?
There are many questions, a few answers. So basically, I mean, we did publish the repeat access chronically or even acutely. So, for example, if for patient will come back the same day, I mean, if there is a pulse, we'll use the same one.
Yes.
That's I would say, the routine. The main limitation, as you said, this has been a long crusade. The main factor for me when we still have to fight is for many old radialists, like in my hospital, we've been doing radial for 20 years, the risk of radial arterial occlusion is basically considered as a innocent bystander. So we are very bad. The rate I've been publishing that my rate of radial arterial occlusion in ongoing trial is something like 20% on the same day. They will always claim that we know that some of maybe 50% of radial will reopen, but the reality, and we published that, in fact, every time patients were coming back, and sometimes they came back 10 times, every time in 5% of the case you cannot re-access the radial artery.
Right.
So we are bad. If you look at the most recent trial, when the new generation of radialists have been taking the radial arterial occlusion in the equation of patient care, I mean, they are much better because, I mean, that's a way for us to move from femoral to radial. And so they can use, I mean, I would say new device to get the hemostasis. So the rate of radial arterial occlusion acutely is probably more 1 and 2% in the places when they focus on this. So that's the main thing that we did a survey at the some years ago in 2010, I think that we published it, that I look in the world, and 90% of radialists will use the right radial.
Yes.
For positioning.
Yes. Yeah.
And there are still some guys in the world that prefer the left, claiming that there is less curvature, it's easier. I will tell you honestly that I basically hate the left, especially with the type of patient we get in North America. You have to bend over, so it's difficult. Coming to the question you mentioned before, not to try to speak too long, but We do know, of course, that there is an injury. I mean, you were saying 6 months. There are also some studies looking at the endothelium dysfunction, which are closer to 3 months. So let's say that there is an impact for 3 to 6 months. And when we wrote the paper with Mario, it was very interesting because the reference for us as cardiologists to say, well, I mean, I don't want to skip the benefit because I don't know if the patient will go for surgery. But you have to know that there are many ways we are trying to promote the radial use, and there is a new kid on the block for radial. I mean, it seems that especially the young radialists, what they enjoy now is to use what they call the snuff box approach.
Yes.
And I've been begging for evidence, I've been begging for data, not, like, because it's a buzz, it's on Twitter, Facebook, but would like to have some kind of hard evidence. This is something that the patient likes, most of them, and the hemostasis is so easy.
Yeah.
And in fact, you could think that, and the radial rate of occlusion seems very low. So you could think that, in some cases, when we were discussing ulnar versus radial, which is also an option to use the ulnar, well, I mean, we don't know, but maybe, I mean, the snuff box approach could also be a way of preserving the main part that you can use as a surgeons. But I predict you're going to spend some years still to convince your colleagues about using radial. It's not going to be easy. I mean, I can tell you by experience.
Yeah, I mean, in our centre, we've seen a big shift in the last few years from femoral to radial, both in elective and acute settings. So, Mario, how do you convince the cardiologists at Cornell not to use both radial arteries?
No, I mean, they want to use one. But my point is just, I mean, David, the good thing is that we have two radial arteries. So now we go back to the initial presentation by Filippo on the importance of the heart team approach. We have to know that the radial artery approach is extremely important for diagnostic and PCI. So we as a surgeon need to be aware of that. And the interventional cardiologists need to be aware of the fact that the radial artery is important for CABG. Clearly, the right and left rule, and that, by the way, that was your rule, so I give you credit for that. It's a great, easy rule to follow, but then there might be a little bit more individualization. We, as a surgeon, we physically take out the radial, so we really need a good ulnar compensation, whereas for PCI, ulnar compensation is less important for the transradial approach. So maybe this is also something that comes into the equation. You can evaluate the degree of ulnar collateralization and decide which approach to use for CAT and which one to use for surgery. In general, working together, we are able to find a solution.
Filippo, please.
No, very simply, God himself made a mistake giving two radial arteries. That was the original mistake. They are not enough, but with two radial arteries, I think that the simple principle, right to the interventionalist, left to the surgeon, and what is left has to be discussed in the heart team. I think this is the very simple algorithm we should follow.
I think God made an even bigger mistake than giving you only two radial arteries. He only gave us two internal mammary arteries. It should have been three.
Yeah.
And finally, Dr. Bertrand, do you want to...
Mario, I mean, when you talk about ulnar compensation, as you know, we have been working and fighting against many myths.
Yeah.
And for many years, still in some places, people were claiming that we had to use the Allen test or the oximetry to decide. I mean, in one word, that was all bullshit. I mean, there was never any relationship between the evaluation before and the risk of distal something. We had some evidence of even amputation, but this was always because of distal thrombotic events, which were not predicted by the Allen test. So I would suspect that, I know that as a surgeon, you will recommend some kind of pre-test before harvesting the radial artery. I'm not so sure. I think that in many cases, probably you will find later on that it's not required, or you can train the patient maybe also if you can plan the surgery.
Yeah, but don't
get
forget
the radial artery.
You puncture the radial. We take the radial out.
I know.
So it's a little bit, in terms of arm circulation, the consequence for us is just an acute interruption of the circulation. For you is something different. But I think we need to move.
Yeah, Mario, thank you very much. Thank you for all the comments, but we do need to move on. And now Dr. Steve Fremes is going to talk about OPCABG, flowmeter, and even more.
Thank you very much for inviting me. And for everyone who is involved in the new revascularization guidelines, I want to thank you. They're really very thorough. They're a great resource, and I refer to them very regularly already. So these are my disclosures. So in terms of the new guidelines, the ones that I will address: limited aortic manipulation, a class 1, pre-op CT, class 2A, epiaortic assessment of the aorta, 2A, routine transthoracic flowmetry, 2A, OPCAB and no touch for patients with a hostile aorta, a class 1, and OPCAB if it is performed by an experienced team for high-risk patients. So my objectives are to review OPCAB, epiaortic ultrasound, no-touch aortic technique, and flowmetry. There's been a great deal written about off-pump surgery. This is the largest meta-analysis. It came out in the last year. Altogether, over 1 million patients were assessed short-term. These are both clinical trials and observational studies. And they have up to 60,000 patients at 10 years. And the overview is that in the short term, there are benefits to off-pump surgery. However, with further follow-up, there's increasing risk. Now, for someone who has a low risk of surgery, this relative benefit is probably not important. For someone who's high risk, this relative benefit is important. However, if you look at it the other way, in someone who's low risk, this change in the long term might be important. For someone who's high risk, maybe this isn't so important. So I think the concept of risk is very important when you determine on or off pump surgery selection. This is another meta-analysis just focusing on the short term. And basically, in the short term, the relative benefit of OPCAB is greater the greater the patient's increased risk. And over here, the greater the risk of surgery, the greater the relative benefit of off-pump. Now this is for mortality, it's also true for stroke, and it's also true for myocardial infarction. These are the two largest randomized trials in off-pump compared to on-pump surgery with 5-year results. And the conclusions are quite different, Ruby versus Coronary. In Coronary, it looks like off-pump surgery is safe and equally as effective as on-pump surgery, but that's not the case for Ruby. So why is that? Well, it's been hypothesized that the coronary surgeons, or the reason is that the coronary surgeons were more experienced in off-pump surgery than in Ruby. And this brings up the concept of a surgeon-volume outcome relationship, which is really quite evident in a number of operations. And how can that be assessed? Well, with an increased rate of conversion or crossover, that may lead to more early events. And also, this is also a signal that there may be incomplete revascularization, which we heard earlier is very important in terms of the long-term outcomes of patients. We followed up on that, and in a meta-analysis that's in Press, we looked at the volume outcome relation, and we only used randomized trials. 104 trials were included, 20,000 patients, and we used the percent of crossover in the study as an estimate of surgical experience. Altogether, there was greater mortality in the off-pump patients, so that was consistent with the overall results in clinical trials and observational series. However, if you then looked at mortality increased with crossover rate greater than 10%, which suggests that the volume outcome relation is important in terms of off-pump surgery. These are some of the factors that favor CABG versus PCI. These are some of the factors that favor PCI. I would say the same concept is true if you're recommending on versus off pump. And I would specifically say of these, a hostile aorta, renal dysfunction, multiple comorbidities, and perhaps advanced age alone. So I would editorialize that overall off-pump surgery is associated with better short-term outcomes but worse long-term outcomes. However, there are many patients who are at higher risk who may benefit from off-pump surgery. Given that off-pump surgery is technically more demanding, there is likely a volume outcome relation. Finally, I don't believe that every cardiac surgeon needs to be an off-pump expert, but every cardiac surgical team needs to have at least one off-pump expert. That is in the patient's best interest. So this is a hostile aorta, and this is one of the reasons why a no-touch technique might be clearly important. In this patient, you can see it on CT scan, but this patient may have a normal CT scan, but it's only with epiaortic ultrasound that you'll see abnormalities. The presence of an abnormal aorta has been recognized for a long time. This is by Nick Kachoukas approximately 30 years ago. And using earlier versions of epiaortic ultrasound, they found ultrasonic imaging of atherosclerosis in 29 or 58%, but visual or palpable evidence in only half that. And this led to a change in practice in a quarter of the patients. Does epiaortic ultrasound reduce perioperative stroke? There's no randomized studies or minimal randomized studies, but in a review of largely observational studies, we would concur that it does. The Emory group has been very interested in epiaortic ultrasound for a long time. They would emphasize that in an institution where the overall incidence of stroke was 1.4% for coronary bypass, it was 0.6% in a no-touch aortic group, 1.2% in a clampless group, and 1.5% in patients who had a clamp, whether it be on pump or off pump. And they use epiaortic ultrasound routinely. In patients who have a grade 4 or 5 aortic disease, they use either no-touch or clampless device. And here you see the mean grade, and here you see that the patients who had no-touch, a lot of them had grade 4 or 5 atherosclerosis. If they had a clampless device, a lot of them had grade 4 or 5 atherosclerosis. However, the observed rate of stroke was lowest in these groups and expressed as an OE ratio, the lowest in these groups as well. It's extremely important to remember that early stroke is much higher in CABG than PCI. This is mainly seen early, but there's no real catch-up later. And in the editorial that accompanied this, this finding was also consistent in large registries in the United States comparing PCI or CABG, or also comparing TAVR and SAVR and even mitral procedures. So it seems to be a class effect, not just limited to revascularization. Looking more carefully at aortic manipulation, this review from Sydney looked at 13 studies over, close to 40,000 patients. It was a network meta-analysis, which is takes advantage of both direct and indirect comparisons. And this is a summary that a no-touch compared to an OPCAB with a heartstring was associated with a 50% reduction in stroke, compared with a partial clamp, a 66% reduction in stroke, and compared to CABG, a 78% reduction in stroke. And if you then rank all the various possibilities, overall, in terms of stroke, aortic was best, CABG was worse. In terms of mortality, aortic was best, and CABG was worse. And we looked at a variety of pre-stated endpoints. Aortic was the best approach, and CABG the worst approach, except for myocardial infarction. I'm now going to talk about transit time flowmetry. On the right side of the panel is what you want to see. Reasonable flow, a low pulsatility index, good diastolic fraction, not much backward flow. On the left side of the panel is what you don't want to see. More than 10 years ago, D. Gianmarco from Chieti talked about whether these measurements are associated with graft patency. 157 patients had protocol-driven CAS. These are not symptom-driven CAS 6 months afterwards. Of the 157 patients, there were 38 grafts that were occluded, 266 that were patent. And if you looked at the mean graft flow, the average in the occluded was much less than the patent. And if you lose the cutoff of 15 mils, occluded was 95% versus 13%, an odds ratio of greater than 20. If you looked at the pulsatility index, the average was higher in the occluded than the patent group. And if you used a cut point of 3, it was 66% versus 22%, an odds ratio of 3.5. And if you looked at backward flow, again, higher in the occluded and versus the patent, and the odds ratio is 3.5. That's what they use. There have been other thresholds recommended, thresholds of 20 and 30. In reviews, we can see that in general, vein graft flow is higher than arterial graft flow, and it's been suggested use as high a flow of 40 for veins, 20 for arterial grafts, and in terms of pulsatility index, 5 has been recommended as a threshold rather than 3. Some of the principles, you should do it before and after protamine. You need to use an appropriate size probe, not too large, not too small. The blood pressure needs to be high enough. If you're using sequential or composite grafts, you should check all limbs. And it's important to remember, although we try and construct perfect anastomoses, the problem may not be the anastomosis. There may be a graft injury, graft kinking, external compression from a chest tube, competitive flow, or low blood pressure. In other words, despite the fact that the anastomosis may be perfect, unless you look, you may be missing something. Here, for example, is a composite graft, and there's a large amount of diastolic flow. It was switched to a free graft, and the flow has been improved. Here, the waveform looks very good, but the flow is only 13 mils per minute. However, the systemic pressure is 86. Pressure is increased. The flow gets increased to 71. There does seem to be some change in whether you place the probe distally versus proximally. In all practical terms, it's much easier to stick it in the middle of the graft, although the flow does change, probably related to the compliance of the graft. Obviously, the flow won't change itself. Whether you use the right or the left, the flow characteristics are largely the same, except for the diastolic flow. They're approximately the same. The largest study that compared graft patency and transit time flowmetry was a sub-study from Ruby. 501 of the Ruby patients had transit time flowmetry, and this was largely related to the VA center practice, not characteristics of the individual patients. 2,700 grafts. Of these, 62% had 1-year angiography. The revision rate of grafts overall was about 2%, although if you did transit time flowmetry and a low flow, it was 7.7%. If you used a pulsatility index of 5.8% relative to the 1.9% overall. In other words, transit time flowmetry did seem to affect your graft revision rate. And if you did revise grafts, 76% of them were patent. If you compared revision rates overall, compared to less than 20 versus greater than 20, higher overall, and this was the case for veins and IMAs. If you looked at pulsatility index overall, more revisions, the greater the pulsatility index. However, this was largely for IMAs and less so for our vein grafts. Is this a reasonable diagnostic test? Well, not so great for sensitivity or positive predictive value, better for specificity or negative predictive value. And did it correlate with graft patency overall? Yes, it did. Low flow, 71% graft patency, high flow, 87%. And pulsatility index, it was inversely related to the pulsatility index. A low pulsatility index, 85%, greater than 5, 67%. To try and improve with the problems with sensitivity, epiaortic cardiac ultrasound has been added. So not epicardiac ultrasound. And you can get flow images of the coronary like this. Routine transflowmetry in this study was performed as well as epicardiac ultrasound, and the flow probe is 15 megahertz and fairly small. 770 grafts were studied. Of those who had transit time negative, there were close to 700 transit time positive, and then they all underwent epiaortic ultrasound. What we found is that there were changes in the strategy with epiaortic ultrasound. 3 grafts that were negative by transit time were positive by epicardiac ultrasound, and they were revised. And in terms of those who were negative, the decision was changed as well in some of those. And so what happened is that the sensitivity was not that different, but the positive predictive value increased a lot. This will be about my final slide. There are other ways to assess graft flow. One of them is intraoperative angiography, not invasive angiography, but fluorescent angiography. And we and others have compared transit time flowmetry and ICG. Basically, the ICG angiography is more sensitive than transit time. I'm not saying that it should be used, but the company, which was fairly small, was purchased a year ago by a very large medical technology company. So they may be supporting this, and this may be something that's coming out more in the next few years. So to conclude, off-pump surgery is appropriate for higher risk patients by experienced teams. Stroke is increased with aortic manipulation, that's fairly clear. Epiaortic ultrasound does identify more plaque. A no-touch technique is associated with better outcomes overall, and it should be the standard of care in patients with a hostile aorta. Transit time flowmetry is correlated with graft patency, but its accuracy is increased with epicardiac ultrasound as well. Thank you.
Thanks, Steve. Great presentation. Any comment from the audience?
The one comment I would make that's become increasingly clear over the last year or two, and maybe we were a bit naive in retrospect, but for instance, when we designed the ART trial, we said the surgeon had to have done 50 cases. And that's the surgeons who entered the trial claimed they had done that. But in the ART trial, we saw the individual crossover rate from bilateral to single ITA per surgeon varying from 0 to 100%. And I think you illustrated very clearly that same effect comparing the Ruby trial for off-pump, where the surgeons were less experienced, they only had to have done 20 cases, and the Coronary trial, where they had to have done over 100. So I think, and I know Steve and Mario have taken this into account in the trial they're currently leading, the Roma trial. But if I was going back to revise what we did in the ART trial, we'd have been much stricter about ensuring that the surgeons had actually done what they...
Yeah, no, that's a great point. And in terms of generalizability, I think that if you have only expert surgeons, the results may not be applicable in the real world. But unless you have expert surgeons, you may be missing the signal. And obviously there's some sweet spot in there that will prove both points, but that's an excellent point.
Yeah, but you see, David, Steve, this is go everything in the same direction. The use of, for beta, we have a volume outcome effect. For off-pump, we have a volume outcome effect. And then if we think of an aortic off-pump, which is even more complex, I think the volume outcome effect will be. So at the end of the day, I think we are saying that 50 years after Favaloro, CABG is becoming an operation that should be performed by expert surgeon. I think that's the bottom line.
Great question.
Okay. Thank you. Thank you, Steve. Let's move to the next presentation. Stuart, just go to give your presentation.
Okay, I'm going to make up a little bit of time here. That's good because we're behind schedule. So my talk is about CABG versus PCI in patients with acute coronary syndrome. So thank you very much for the opportunity to present here. How often do we do CABG in patients with acute coronary syndrome? For some reason it's, there it goes. I have no declaration of interest. The role of CABG in acute coronary syndrome, if you look into the Plato trial that randomized almost 19,000 patients to clopidogrel and ticagrelor from 2006 to 2008, you see that about 11% of the patients that were initially admitted at the cardiology department underwent surgery, and then about 60% of the patients, this was done within the first initial hospitalization. Even in the EACTS trial that was presented about 2 years ago, and we are all aware of this trial, of course, randomized patients in 2010 to 2014 with patients with left main disease to PCI versus CABG, and about 15% of patients had a myocardial infarction within 7 days before randomization, and this was largely due to non-STEMI ACS. And about 25% of patients had unstable angina, and about half of the patients had stable angina. So actually in the trials that we are discussing over the last few days, we have a lot of patients with acute coronary syndromes included. But of course, an acute coronary syndrome is not always the same. We have different entities of an acute coronary syndrome, and I think it's very important that we distinguish between patients that have ST elevation, myocardial infarction, and other groups of patients. So we'll focus a little bit on STEMI patients to begin with. Now, the timing of revascularization, of course, in STEMI patients is critical. Whether they are in shock or not in shock, there should be no delay into the time to revascularization. And I think the next slide already shows you that there is a great network of centers that usually work together in making sure that the patients that are diagnosed with a STEMI into the ambulance are very quick into getting a primary PCI procedure or fibrinolysis. And you will see that there's no mentioning of CABG in this graph. And that is also what is summarized in the revascularization guidelines of 2018. Patients with STEMI should be revascularized or reperfused as early as possible, and a primary PCI strategy is indicated in patients with symptom onset. That is about 12 hours, and CABG should be considered in patients with an ongoing ischemia and large areas of jeopardized myocardium if PCI of the infarct-related artery cannot be performed. So actually, CABG is some sort of a bailout in this case. A routine revascularization of non-ischemia-related artery lesions should be considered before hospital discharge. So this, of course, allows you to, once you have revascularized the culprit lesion, to discuss with your cardiologists and surgeons together whether you should refer the patient for CABG or you do a staged PCI, for example. Now, if we look into what the results are of CABG in patients that had a STEMI, and this is actually not done in 2005, 2008, 13, sorry, apologies. This is a study that has been done a bit longer ago, published in 2000 by Greg Stone, and they found that in patients, 1,100 patients included in the PAMI trial, that CABG was performed in about 11% of patients, and elective in about 43%, and urgent emergent in about the other half of patients. And first PCI was performed in about 1,000 times of these patients, and CABG was performed thereafter for 6%, of which 0.4% was for failed PCI. So PCI is doing very well in STEMI. And PCI was not performed in about 120 patients, and CABG was performed in about 50% of those. And if you look into the outcomes, you see that urgent emergent CABG had about 6.5% mortality in hospital versus 2% in the elective cases, and about 2.6% in the patient that didn't undergo CABG. And of course, the urgent emergent CABG group here includes patients that are very sick. Now, if we look into the timing of revascularization of CABG, in particular in patients with a STEMI, you see that in-hospital mortality is about 6% if performed within 6 hours, and about 9% if performed within the first day. But these numbers are very small, and there is not so much to find in the literature on the timing of CABG in patients with STEMI. And if they looked into the prediction of in-hospital mortalities, you will see that cardiogenic shock obviously is one of the most important predictors for outcome if you look into in-hospital mortality. And cardiogenic shock is separately discussed in the revascularization guidelines, and again, as I referred to earlier, emergency PCI of the culprit lesion is really indicated in this case, and emergency CABG is really recommended in patients with cardiogenic shock only if the coronary anatomy is not amenable to PCI, and this is a 1B recommendation. Now, if we look into the results of cardiogenic shock, CABG and cardiogenic shock over the last decade, we've seen that from 2005 until 2013 in the STS database that included about 5,500 CABG procedures, which was roughly 1.5% of all CABGs that were performed in the United States at that time. You see that the mortality rate, in-hospital mortality of patients with cardiogenic shock was 19.3% in 2005, and it went down to 18.1% in 2013, and this was a significant difference. But still, the mortality is high, and obviously this is a very sick group of patients. So in STEMI, I think it's pretty clear. STEMI is the area of PCI, and only if PCI doesn't work, we as surgeons are called into the room. But non-STEMI ACS and unstable angina is a little bit of a different group, and I will focus on that now, and you will see that in a nice analysis done of 3 trials that compared CABG with PCI in patients with non-STEMI ACS, the Syntax trial, the pre-combat trial, and the BEST trial. So this included patients with multivessel disease or left main disease, and this is about 1,300 patients, and up to 5 years, the primary endpoint of major adverse cardiovascular or cerebral events. So this includes mortality, death, stroke, and repeat revascularization. Mortality, myocardial infarction, stroke, or repeat revascularization. There was a lower incidence of this endpoint at 5-year follow-up with CABG as compared to PCI, and this was statistically significant. So there appears to be some evidence that CABG is doing better than PCI in non-STEMI ACS. If you break it down from the 5-year incidence of MACE to death, you see that there was actually no difference between the groups, not statistically significant at least, but there was a significantly lower rate of myocardial infarction during follow-up after CABG than after PCI. The rate of stroke was not statistically significantly different. And this is a very nice other study that was recently published last year in JACC in about 5,000 patients. It was a Canadian registry that looked onto diabetic patients and compared CABG versus PCI with and without non-STEMI ACS. And if you look into the composite endpoint of MACE, you will see that at 30 days, there was actually a lower rate of major adverse events in favor of CABG as compared to PCI. And if you break this down, there was no difference in death. There was a highly significant difference in favor of CABG in myocardial infarction, although there was a higher rate of stroke favoring PCI. And I think this is something that at least at 30 days we see in many other trials as well. So this is very likely to be consistent. And if you look into the long-term follow-up, you see that favoring CABG, all of the point estimates favor CABG in this case, so major adverse events, death, MI, and repeat revascularization, while for stroke, an event that occurs very infrequently during follow-up, you will see that there was actually no difference, but the confidence intervals are quite wide. So this adds to the previous study from 3 trials that were pooled, that the benefit of CABG is clear over PCI in patients with non-STEMI ACS. So this is why the new revascularization guidelines have added a recommendation that was not included in the 2014 guidelines, and that is that it is recommended to base the revascularization strategy on the clinical status and comorbidities as well as the disease severity according to the principles of stable coronary artery disease. The Canadian registry that I just showed you did a very nice analysis on with versus without ACS as well, and they actually found that the decision-making between patients with and without ACS, so patients with ACS versus stable, was exactly the same, and the results were consistent in both groups. So you can think about following the same decision tree for patients with free-vessel left main disease, irregardless of whether they have had non-STEMI ACS or they have stable disease. And those of you who have been in the room for the last 2 days have probably already seen this slide, and this is just to summarize the way that we decide whether to go for PCI or CABG according to the latest revascularization guidelines. Besides this, and this is also something that Steve Fremes just showed you, there are always aspects to consider whether you need to go for PCI or CABG that are outside of the graph that I just showed you. So there's always comorbidities or anatomical complexities that could favor CABG or favor PCI in particular patients. And that is why I want to finish this with saying that the multidisciplinary heart team is as important as in patients with ACS as it is in patients with stable coronary artery disease. And to summarize, I'd like to say that CABG remains an important strategy in ACS patients. Although primary PCI is really indicated for STEMI, CABG is a backup for when PCI fails. PCI or CABG and non-STEMI ACS and stable coronary artery disease should be followed through the same algorithm, but it remains crucial that heart team decision making is in place in all the institutions in Europe. Thank you very much for your attention.
Thank you, Stuart. Brilliant presentation as always. So you just mentioned the importance of the heart team. In the interest of time, I think we have a live heart team now from the Catholic University, so we will skip question for you. Maybe we will ask question later. So do we have the the Catholic University ready?
I think it makes sense.
Does that mean that you're not doing target vascularization anymore? Obviously, the guidelines are very new, but yeah.
It's difficult to say one word. The only thing I think that you should remember that non-ST elevation, it's a marker of multivessel disease, so that's why you choose. There are more diabetes and more multivessel disease.
To all of you, and welcome to the live art team of our cardiovascular department located here in Rome in the Gemelli University Hospital. Here we are in the meeting room of our heart team that we organize on a daily basis from Monday to Friday morning between 8 and 9 o'clock. I'm a cardiac surgeon. I'm pleased to be here with Professor Gaetano Lanza, cardiologist, and you will assist to a session of our meeting in which we discuss the case of the complex case of cardiovascular pathology in order to share the best approach for each patient. In this meeting, there are all the specialists of cardiovascular area cardiac surgeon, interventional cardiologist, arrhythmologist, clinical cardiologist. And this is a real multidisciplinary meeting in which we discuss every case, the comorbidities of the patient, in order to decide the best approach in the clinical pathway. In the few minutes, and since the last year, we have developed also the so-called ER team. This is a meeting with few spoke hospitals in order to share the decision of a complex case in patients that are located in the spoke hospital, so far from our department.
Okay, thank you.
But we start to the discussion of the first case. I will ask to Gaetano to introduce the case and the discussion.
Thank you, Massimo. I would like to welcome you to our team meeting.
Team meeting. The first case would be presented by Dr. Domenico Damario and concerns a patient with severe coronary artery disease and valve aortic stenosis. Please.
Good morning, everybody. Dear colleagues, Chairman, good morning. So I would like to present the case of a 63-year-old Caucasian man with a BMI of 23.4, hypertensive, smoker, presented in our institution with a non-ST segment elevation of myocardial infarction. The EKG on admission shows sinus tachycardia with repolarization abnormalities, and also we were able to find a slight increase in troponin on admission. The chest X-ray, I would like just to mention that there was a slight dilation of the ascending aorta that appeared calcified, but there were no signs of pulmonary edema or congestion. This patient had no previous medical history, although there were some relevant comorbidities. In 1987, he underwent a left renal transplant for nephrotic syndrome caused by membranoproliferative glomerulonephritis. However, in 2003, he underwent again to nephrectomy for severe graft disease, and he had an history of HCV infection, although he's currently seronegative due to a therapy with sofosbuvir. Actually, now he's on dialysis. On admission, the risk stratification score, the GRACE and CRUSADE respectively, point to an intermediate risk related to GRACE and high risk for bleeding, as pointed out by CRUSADE. The echocardiography performed on admission show a left ventricle dilation with systolic dysfunction and hypertrophic septum with hypokinesia. We were able also to see an intermediate stenosis of the mitral valve and severe aortic stenosis, and is highlighted by an area of 0.7 and a maximum gradient of 70 millimeter of mercury. The patient underwent also a coronary angiography. You can see on the left panel a chronic total occlusion of the RCA, a stenosis of the circumflex, and also a critical stenosis on the proximal LAD that is aligned also in this steel frame shot with red rectangle. A very gentle PCIO on the LAD was attempted in this patient that actually has a 3-vessel disease. He underwent also a CT scan in order to evaluate the axis and the calcification. And as you can see, there are several calcification on the femoral iliac axis in both the right and the left. There were also on the abdominal aorta and the aortic arch. The risk score were calculated as well, and the syntax 1 score was 44, and then when was implemented to evaluate the syntax score 2, as you can see, there were the treatment recommendation was for CABG due to a very high mortality with PCI. The STS score that was calculated for the procedure of AV replacement plus CABG show a risk of mortality of 6.9% and morbidity and mortality of 31.6. Also, in order to evaluate the frailty of this patient, the frailty score was evaluated and the patient was classified as a pre-fail with a score 2. Therefore, finally, we were facing a difficult crossroads and 4 options were highlighted. The first one was to optimize the medical therapy due to the high risk, both for percutaneous or surgical approach. On the other way, do all surgical with CABG or AVR. The third option that we would like also to have on the table and to discuss was to progress with aggressive PCI in order to treat at least the LAD with the intention to complete the revascularization, and finally an hybrid approach with off-pump CABG and transaortic TAVR. Can you hear us? Can you hear us? So going back to the 4 options that we have, because we are not able to hear you from Milan. So
No, è bloccato.
Yeah. So this is David Taggart, one of the panelists. So we can hear you, and we can now.
Can you hear me?
We can hear you now. Can you hear us?
Can you hear me?
We can hear you, but I think it's one way.
Yeah. It was like that, yeah.
Sorry, I was not able to hear you. So I don't know where you were able to follow us.
We could hear your description of the case. Can you hear us?
Sorry, can you speak a little bit louder?
I'm speaking pretty loud.
Yeah, maybe I'm not able to hear you, but now much better.
Oh, thank you. Okay, so we heard that my name is David Taggart. I'm one of the panelists, along with Mario, Gaudino, and several others. We heard the description of the case very well, but we did not see the coronary angiogram.
Okay, so I'm going back. Those are the 3 videos. Are you able to see now?
Yes, we can.
So I will start again. The RCA, chronic total occlusion on the RCA, spot lesion on the circumflex, highlighted by here, and then again on the LAD, on the proximal LAD. You can still see in this still frame. There was a gentle attempt done on the LAD, but finally we end up with a severe calcified 3-vessel disease.
Do you have an FFR of the LAD?
Sorry?
Do you have an
No, the FFR was not done because we believe that already by the angiogram was considered critical stenosis.
Because I couldn't, when I look at the LAD, I cannot see the significant stenosis on this view.
So if you can see at least where the arrow is, I think that at least in this spot is pretty critical.
I am not convinced.
Okay, so we will see later if you're able to convince you at the end. But as I was saying to you, there was also a gentle attempt done on the LAD. We were able to pass the wire, but were not able to pass the balloon. So I think that a severe calcified stenosis is there.
Ask him about the
Well,
severity.
David, this is...
Ask him about the severity of your stenosis. We didn't hear that part.
David, this is an equivalent of FFR. If the balloon doesn't go, must be critical.
I think that's
It's a surrogate of FFR.
I think that's a good. But Domenico, what are the other? Okay, fine. So now we got to we have seen the angiography. Can you show? Yeah, show us the CT.
So you were able to see, I don't know if you were able to see it before, the CT scan
No,
was
no,
done
okay.
to evaluate the access and also the calcification on the aorta, severe tortuosity and calcification on the femoral axis, on the aortic axis, and also on the arch. You can see in two projections in order to see here and also very close to the arch. See, I don't know if you were able to see also the score that we calculated. The syntax score was 44. When we implemented this to calculate the syntax score 2, we end up with a treatment recommendation for CABG, and the STS score that was calculated for AVR and CABG show a risk mortality of 6.9% and morbidity and mortality of 31.6. Frailty score was also calculated, and this patient was classified as a pre-frail patient. Therefore, as I was saying, we were facing difficult crossroads with 4 possible options. On one end, you optimize the medical therapy, since we may consider this patient too high risk either for percutaneous or surgical approach. On the other opposite, go for surgical approach, CABG plus AVR. Third option, reattempt the PCI on the LAD to treat at least the LAD with the intention to complete the revascularization, and then plan a stage surgical or percutaneous repair, or AVR. Finally, an hybrid approach with off-pump CABG, Lima on the LAD, and a transaortic TAVR.
Okay, Domenico, I think now we have the full picture, and so I think we have a better idea of the patient. So let's start asking to our panelists, and then everyone in the audience then want to share opinion.
Yes, Mario, can you hear me?
Yeah, we can hear you. We can hear you.
So we would like to discuss briefly this case, because if we look to the pathology, to the indication, there is a formal indication of combined surgery, CABG plus AVR. But we would like to discuss the problem of the risk, of the operative risk, because he's a patient with many comorbidities, is a fragile patient. So if we can discuss about a different option of the conventional approach with combined surgery, like staged approach to the valve and to the coronary, or other options. And so I would like to ask to the audience which are the main position of the different colleagues that are represented in this meeting. So
okay. So we will ask here for Filippo. You're very used to this scenario. So what do you think about that?
Oh, well, I have just 2 comments to kick off. The first comment is that this is what we do every day, and we strongly believe that this is the way to go for complex patients. The second comment is that this patient is not in trials. So whatever we do has to be based on our best judgment. Third comment, in addition to comorbidities, the aorta was severely calcified, the ascending aorta, making your life more complex. So now, what should we do next?
So there are 2 things I am not clear about from the presentation. Did you say it was severe aortic stenosis?
Yes.
It is severe?
Yeah.
The second
it was missed, but it was a severe 0.7, 0.8 area.
Okay. In terms of the aorta, the ascending aorta, which is the bit the surgeon really needs to appreciate, I did not think it was severely calcified. I think most of the calcification was in the arch and the descending aorta. But the bit that we need for cannulation, cross-clamping, and perhaps side-biting for grafts, I thought the ascending aorta was largely disease-free.
Domenico, can you show the aorta?
No, not really.
CT scan. Can we have the screen?
So here's the aorta again.
So now the word is to your surgeons.
Sorry, can you show again,
Filippo.
Can you show again the aorta, please?
We show the aorta, but this is only one image of the reconstruction of the ascending aorta. But when we look to all the exams, we look that there is a real pathology of the ascending aorta with big calcification in the distal part of ascending and the arch. So this is typical, difficult patient to perform a safe cannulation, and we have to discuss this option.
Just to clarify for the audience, the aorta that we would normally worry about is the porcelain aorta, where the whole ascending aorta is calcified, but it is not here.
Okay, I think this is one of the components. Can you show the surgical risk, Domenico? Because in addition to these potential complexities, because of comorbidities, the surgical risk was pretty high, less than PCI, but definitely high.
Yeah.
So here we have these three options. One is to go for medical treatment.
Yes.
The other is to go for surgery. The other is to go for a hybrid approach. What would be your choice?
So let's ask the panel from the interventional cardiologist perspective. Olivier, what would you do? Would you try a high-risk PCI on that LAD, or you think that is just not?
Well, I would just make two comments. First, in terms of imaging, since they did the angio scan, it would be nice to see the coronary arteries by the angio as well. To see, it looks like the right is just a chunk of calcium, so I would be very interested to see.
The right is occluded.
Yes.
The artery.
No, I know, but I haven't seen the left system by the angio CT, so I think it would be also very interesting to see, especially considering that they tried to do PCI. The second aspect, if we are not in a very acute situation, why not take some time to make some imaging and measure the level of and the distribution of the ischemia burden to make the decision process perhaps stronger. I mean, it's to me it's quite obvious that if we can accept the risk of surgery on a long-term basis with a combined gesture on the valve and the revascularization, it will win. The problem is how you can go for the acute, how you can manage the acute risk. I mean, if we go PCI, it's going to be very palliative because the long-term and the midterm would not be good.
Okay, Steve, your surgical.
Mario.
Oh yeah, Massimo.
Mario, we have a suggestion from the audience here in Rome.
Yes, tell us.
I'm Pier Giorgio Bruno. Good morning, everybody. I'm a cardiac surgeon here in Rome. Good morning, Mario.
Hey.
And as usual, I think every choice that Domenico da Mario mentioned carries a high risk in a patient like this. That is not an unusual patient in our morning discussion. I think that the angiography showed us a main problem on LAD that was not the bespoke interventional cardiologists were not able to treat, and that our cardiology, interventional cardiology that are with us today are very are not sure to join to have a good result with percutaneous therapy. So I think the main problem is the LAD and the aortic valve. For surgery, we are convinced that the aortic pathology is too risky for a standard operation, and so my suggestion is to try and to discuss an hybrid therapy on the patient. So the treatment of the LAD with an off-pump surgery that seems to be possible, looking at the LAD in its distal segment, and maybe a TAVI on the aortic valve that seems to be difficult for the access, for the vascular access, but may be possible from the aorta.
Okay, so
I don't know what do you think about this.
Okay, I think we got that, but we have
Excuse me, Mario.
different.
Mario,
Yes, one second, Massimo. We have a different opinion here. David was saying that probably the aorta is not so hostile. So I want to ask Steve on the panel. Do you think that the aorta is preclude any conventional surgery? Or do you think conventional surgery is an option here?
I think if you looked at every scan on the CT, there may be one that is clear, but I would say overall the aorta looks hostile.
Okay.
One thing wasn't clear in the presentation was whether they thought there was reasonable iliofemoral access for a transfemoral, or whether there was reasonable axillary access.
Now, Pier Giorgio was mentioning that they think there is no, the femoral access is complex, but they can explore alternative access, transaortic access.
Well, I didn't think it was good for transaortic because there didn't seem to be a healthy part in the distal ascending that was free of calcium. You need, 7 centimeters or a bit more to comfortably put in a transcatheter valve from a direct aortic approach, and that's where a large burden of the plaque was. So I didn't think this particular patient was a good one for transaortic.
Okay, so Massimo, what were your options for TAVR? What was your access option for TAVR here?
We usually discuss patients like this in a hybrid approach, but in the majority of cases, we decide to do a staged approach. First, revascularization and then TAVI. But in this case, if we consider the difficult peripheral approach, we decide we propose to perform a combined approach in the same time in a hybrid room, an aortic valve replacement and a LIT CABG. Would like to know if our interventional cardiologist Carlo Trani wants to do a comment.
Thank you, Massimo. Good morning, everybody. Yes, obviously in this case there are several options. I mean, from our point of view, we could do PCI and TAVR in a staged procedure. Also, combined surgery is an option, as Domenico showed. The discussion here is what is the most striking procedure with less risk for the patient. This is a young patient with a diseased aorta, both in peripheral and in ascending aorta. So the idea to be minimally invasive is quite appealing. We have the chance to operate on both coronaries and valve at the same time with minimally invasive approach. We discussed a lot about this patient, which is the best way to do TAVR, for example, transfemoral or transapical or transaortic. Okay, the aorta is diseased, but as you pointed out, the disease is mainly confined in the upper part of the ascending aorta, where the clamp, I think, has to be placed. Also on the back, right? But the anterior part of the aorta is quite free from disease. So we believe that using the same access, sternotomy for Lima, for CABG, for minimally invasive Lima LAD, and transaortic TAVR for this patient could be really an appealing solution. This is what we discussed about.
Thank you, Carlo. We have no many time, but we will show you what we.
No, Massimo, wait. Massimo,
could I make a comment, please?
Massimo, wait a second.
So I think I will give you the benefit of the doubt that the patient has severe 3-vessel disease, although on the angiogram I saw, because it was small, I couldn't see it. But if the patient has severe three-vessel disease, then it is justified to do off-pump CABG to revascularize. But remember, this patient is on renal dialysis, so the 5-year life expectancy is 50%. So if the patient does have severe three-vessel disease, it would be entirely reasonable to do off-pump CABG times 3 and a transaortic valve under direct vision. But in my centre, we cannot do that. And I personally would not turn this patient down for a conventional aortic valve replacement. I completely accept it would be higher risk because of the aorta, but I would say the ones that I say are not operable are those with the porcelain aorta. But there's a lot of disease-free ascending aorta in this patient, in my opinion.
Okay, so in summary, this is a patient with non-stable and severe aortic disease, severe comorbidities, and let's say complex ascending aorta. So coming to possible solutions, we can go percutaneous, we can go surgical, or we can go hybrid. Before giving you our solution, can we go through us and make a suggestion, Mario? Option 1, 2, or 3?
Well, I would definitely go for an off-pump revascularization of the LAD, which is an easy, straightforward operation. And so potentially the idea to do TAVR within the same setting using the surgical approach is very attractive.
David, and so on?
If you're going to revascularize, you do 3 vessels, assuming that the right coronary is a reasonable size target. So I would do off-pump CABG times 3, plus if you had the access to do a TAVR by a direct transaortic approach, that's what I would do.
Please, let's go
Steve?
around just before the conclusion.
So is the circumflex felt to be suitable for PCI?
Well, the right was occluded. The circumflex was small and diffusely diseased.
I think I would recommend grafting the LAD and some transcatheter procedure for the aortic valve, whether it's direct or transfemoral or transaxillary.
Olivier?
I would, well, I mean, my view as a cardiologist will say that I will still believe to quantify the ischemic burden, see if I can justify in that case to have a complex PCI only on the LAD, and then discuss the TAVR with the multidisciplinary team. Or if there is extensive ischemia, then I will rely on the surgical colleagues saying that we need both revascularization surgically and valve replacement.
Cristiano?
I do agree as well about the hybrid approach, probably with the off-pump CABG and TAVR. Regarding the amount of vessel to treat, I mean, obviously, ideally, it would be better to aim to a complete revascularization. It really depends how the circumflex looks at the moment, because from the images we found out was quite diffusely diseased, and maybe it might be a little bit challenging to graft, but I believe, according to what we heard also today about the volume and experience of the surgeon, if we actually assume that the center is quite experienced about it, so most probably it's not going to have much problems to perform a complete revascularization, which is basically aimed and advocated by everyone. But at the very end, it's all like a very sensible decision.
Okay,
Mario.
Alicia, 1 second. Alicia, yes. What do you
Yes,
think?
I guess, I mean, it's a procedure for a very expert. And considering our options, I would go for the one access option and graft the LAD off pump and then do the TAVR at the same.
So the heart team in Milan seems to suggest globally that an hybrid approach with off-pump surgery and TAVI is appropriate. Now let's go back to the heart team in Rome with the conclusion.
We have no time, so our solution, Domenico.
We're happy to share that finally we end up with the same solution. Just 1 minute to show our position. We were happy about the hybrid solution. We did the first step to optimize the therapy with ACE inhibitors and beta blockers. This patient was on ASA and clopidogrel, aspirin and clopidogrel. He underwent an off-pump, Lima to the LAD and transaortic TAVR. This is just a clip showing the
scenario of the hybrid room that we have where interventional cardiologists and surgeons are really close working for all the procedure. You can see the sternotomy as well. This is the harvest of the internal mammary artery, courtesy from Dr. Bruno, that is here in the audience. And finally, these are the placement and the release of the valve. And finally, an angiography on the aorta just to show that there were no remarkable regurgitation as confirmed also by the echo done post the procedure. We were able also to check the Lima was patent again and was fine at the end of the procedure, also highlighting that maybe the severity of the stenosis on the LAD was present from the beginning. Finally, there were no major bleeding during the hospitalization, and also this follow-up of the patient is on NIA class 1, and he had no recurrence of angina or ACS after the procedure.
Okay, so it seems a very good result. Congratulations.
Thank you. Thank you, Domenico. Now we have time to connect to our spoke hospital in a network organization, as I said before. So we will ask the colleagues from Fatebenefratelli Fratelli Hospital located in Benevento, hundreds of kilometers from Rome, and we will discuss together with you a difficult case of combined pathology and coronary.
Okay, Massimo, we have 10 minutes because the presidential address is coming. Okay.
Okay. Bruno, can you speak? We have a small technical problem.
We apologize, but there is a little problem with the audio.
Hello? Ecco, continuiamo. Okay. Welcome to everybody from Fatebenefratelli Fratelli Hospital, Benevento. My name is Bruno Villari. On my right is Bruno Ciampi. We are very pleased to show you our ER team that is a different way of cooperation between a hub hospital and a spoke center located in two different regions in Italy. Now we are going to present you a complex case of combined pathology. Dr. Ciampi will ask you.
Hi, morning, the chairman and panelist. Our case is a woman of 73 years old. In the 2003, underwent aortic replacement with mechanical prostatic valve and coronary bypassing double vein on obtuse marginal and the right coronary artery. She had hypertension, diabetes in oral drugs, and dyslipidemia. About 1 year ago, in October 2017, arrived in hospital for acute myocardial infarction, non-ST elevation, treated with PCIO on big left ventricular descending coronary artery and death condition. In echo report were reported ejection fraction 40% at addition that increased at discharge 50% and moderate moderate condition. After 3 months, she arrived in emergency room for acute heart failure. This is the electrocardiogram that showed the increasing heart rate in our hospital admission without signs of acute coronary syndrome. And the echocardiographic exam demonstrated the presence of reduction ejection fraction to 57%. We see akinesia in mid part of the septum and all apex, as it is image demonstrated. However, in addition, we have a severe mitral regurgitation, and the mechanism were related to the restricted movement of the posterior leaflet with severe dental dysfunction, severe right ventricular dysfunction, and pulmonary hypertension. The coronary angiography with restenosis in the mid part of the leg and progression of the disease in the left main. And with the normal function of the bypass on the obtus marginal and the right coronary artery. After 1 week of intensive care, we have significant improvement in ejection fraction, 46% with reduction in systolic and diastolic volume. And we have an improvement of mitral regurgitation, now defined as moderate, in particular with improvement in the motion of posterior leaflet. The right ventricular function improved, also the ventricular function, the diastolic function, and the pulmonary hypertension. The transesophageal echo demonstrated a significant reduction, confirmed the reduction in ejection fraction in different view, and as demonstrated in three-dimensional view, we have in this surgical view a restricted movement in the posterior leaflet, as demonstrated also in this particular with moderate mitral regurgitation. This big slide demonstrated the situation at the admission in hospital, and 1 week later, with significant improvement, as we demonstrated in the ejection fraction, systolic function, right ventricular function. How is the possibility therapeutic option for these patients? The first is a surgery indication in coronary revascularization, mitral valve repair for severe mitral regurgitation. However, I can underline the higher STS score more than 20. The second option is percutaneous revascularization, percutaneous revascularization of left main and left ventricular coronary artery, and start clinical and cardiovascular follow-up for mitral valve regurgitation. I can underline the improvement of mitral regurgitation during hospitalization phase. Third option is a follow-up, which the patient wait the clinical conditions at the time. Okay, thank you.
Okay, so I think we have an understanding of what is the case. Again, Filippo, what are your thoughts?
So we have another difficult case. We can discuss in our meeting in Rome or directly in Milan. What do you think, Mario and colleagues in Milano?
We are discussing. So Filippo, what's your best guess here?
Well, this is another patient who is not in guidelines. The first remark is the remarkable dynamicity of mitral regurg. This lady came with severe mitral regurg, and after full treatment, appropriate treatment, ventricular function improved and the regurg decreased, which is something which sometimes perhaps we underestimate, our ability to improve functional alterations. Second consideration, this is a redo. And redo, as we know very well, is an high-risk condition. So the STS was about 20%. So these are the options. Medical treatment, which is important, but perhaps in this case we can do better. High-risk surgery, or high-risk PCI with support, which cannot be impelled because of the prosthesis. So these are the three options. It would be nice to have, as we have only 5 minutes, perhaps let's go around the table.
Yeah, so let's start. I see Bob Tranbaugh has just joined us. So Bob, is a redo operation a high-risk situation? I mean, the guy had AVR and CABG a while ago. So is reoperation per se a high-risk situation? What do you think?
Well, it certainly adds some degree of risk. And it certainly adds some degree of risk. You know, I was a bit surprised with the STS estimate of 20%. You know, I would have thought more in the 8 to 10% range for this guy, this patient. You know, I would vote for surgery. I think a MAM to the LAD and a mitral ring or replacement, depending on what the valve looked like. I didn't quite see the circumflex circulation. It went by a little too quick. It looked like there was a vein graft going to an OM. Yeah. But then I wasn't sure about the other OM in there also. So you know, I think at a minimum, I would vote for surgery. I think medical therapy is just not going to do the trick.
Okay, so we can move in that direction. So the other panelists, what do you think? What would be your approach in that situation?
Yes, so I guess, as said before, I think there should be a little lower risk. I think 20% is quite high. I would say it really depends on the symptoms of the patient, what we should not forget. I think watch and wait could be one option, and then go from this, and both options would be feasible.
So optimizing medical therapy first, and then look, Cristiano, very briefly.
73-year-old lady.
Yeah, I would probably like push for the revascularization, and
Excuse me, can you speak louder, please?
Yeah. I was saying I'll probably push for the revascularization. It's not clear to me the degree of the MR.
Change.
Yeah, indeed, it's quite challenging, you know, because probably this will also guide the approach on the mitral itself. I mean, if even to do it or not, most probably, since we are already there, most probably some degree of intervention will probably be recommended.
Okay, Olivier, all the surgeons want to operate. You want to do PCI on that?
I think what would clear, I mean, first of all, I mean, there is functional mitral regurg, which responded very well. We have pattern vein graft, which are functioning very well. So definitely I would go for PCI, but I would probably use IVUS to understand why there is restenosis, because it's a failed post-PCI result. Maybe there is underexpansion. It's not an easy procedures on the mid and long-term result, because the options are if you put additional stenting within stents, so you already, or you use drug-eluting balloon with the evidence is quite weak. But I will not use the supported PCI. I think I will go straight forward like we do every day.
Okay. Steve, your thoughts?
Yeah, I would support percutaneous revascularization. Patient would have to take warfarin and Plavix or ticagrelor for a while, and watch the mitral, and perhaps the mitral will get better with further revascularization as well.
So, David?
So I would certainly support the cardiologist here. I think this is dynamic MR. Part of that may be ischemic related. The patient has 2 patent vein grafts, so they do not need redone. And although I am not an interventional cardiologist, that looked a very proximal and quite localized lesion. So if the cardiologist could offer successful percutaneous intervention, I would certainly support that.
Okay, so here in Milan, it's...
May I have the comment, Mario? Sorry, this is Carlo from Rome.
Yes, Carlo, yes. That's our interventional cardiologist from Rome. So, Carlo, here it seems that the suggestion is to go to PCI, that lesion, and see what happened to the mitral. What do you think about that?
Yeah, I think this is what we did at the end. But there is one caveat in this case. The patient has mechanical aortic valve, and the patient already came to the hospital with left ventricular function depression, about 35%. So we were a little bit worried about the response of the patient to the dilation of this very severe and calcified left main. And we could not apply what we apply usually in these cases, that is impella, because we cannot place impella across a mechanical valve. So the decision here is how to support this patient. Is intra-aortic balloon pump enough, or we need anything else? Do you have any opinion on that?
Okay, so we have another problem now that for PCI we need some kind of support. We cannot use the impella through a mechanical aortic valve. So now the question is about the kind of support. The balloon pump is enough, or we need a more aggressive support? I think, Olivier, that's your first, the question that's mainly for you. Would you feel comfortable doing that PCI with a balloon pump, or would you require something more?
I'm biased because we don't have the impella. It's too expensive. We moved away from. We were doing many supported with balloon pump many years ago at the beginning of the experience with the left main. Then we realized that there was no clear benefit, and I would say that we would just proceed again with the imaging-based PCI without any support.
Okay, so Carlo, did you hear Olivier? It seems that here the suggestion...
Maybe Bruno and Quirino can show the result and then you can clarify.
Yeah, I'll show you. Our solution
I don't know what's happening.
Well, if the communication is difficult, perhaps Carlo Trani can sum up what we did.
Okay, so it seems that was the solution, PCI.
Balloon pump.
What they are showing the result. What we did was a PCI, an extensive PCI on the left main LAD, and we were also able to reopen retrogradely the circ because there is the first obtuse marginal that was not, there was a stenosis on the second marginal, so the first obtuse marginal was not properly revascularized. We used in this case intra-aortic balloon pump, but we placed two sheets in the artery and vein just to be prepared in case of hemodynamic collapse to implant ECMO system. So we didn't need it during the procedure, but we were ready to do that.
But Carlo, the most important question is, did you do that through the radial artery? Did you use the transradial approach or the transfemoral approach to do that? Okay, I think in the interest of time we needed to move. Thank you from Rome. Thank you everybody. That was great. And the concept of the EART team of the AB and SPOCAR team, it's really something I see for the first time. So congratulations, and congratulations Filippo that is part of that. I think we can move to the next speaker. Okay, so our next speaker is Tom Schwan from the United States that will discuss how we can improve early outcome after CABG.
Yeah, thanks.
So good morning, ladies and gentlemen. I would like to thank the Association for the opportunity and the privilege of discussing how we can improve early outcomes after CABG surgery in 15 minutes. Mission impossible. But anyway, we'll give it a try. Coronary artery bypass surgery remains the workhorse of cardiac surgery, and it constitutes about 54% of all the entries into the STS database as of 2016. Now, CABG is a labor-intensive and an expensive undertaking, and each additional complication is associated with significantly increased incremental costs. As opposed to the past, where we had sort of a one-size-fits-all operation, the technical complexity of CABG has been increasing with the development of percutaneous and hybrid procedures, robotic procedures, minimally invasive procedures, and multi-arterial bypass grafting. In addition, the patients who are undergoing CABG are increasingly sicker and are older. Yet despite these developments, CABG is still regarded as, quote, as a generic operation that can be performed by any surgeon, not necessarily a CABG specialist. And maybe to improve our outcomes, we need to reconsider that paradigm. So in the STS database, the risk-adjusted mortality rate for CABG in the United States is 2.2%. And as you can see, that over the last 10 years, that has not changed dramatically. 12.3% of patients will experience a major morbidity. 37.5% will experience any morbidity. 43% of patients will require a blood transfusion, and 15% will be rehospitalized within 30 days of the operation. So if we compare the outcomes and the risks of mortality of CABG to other highly specialized and complex fields, this is several orders of magnitude higher than, for example, commercial airline flights and nuclear power. In fact, CABG is about as safe as alpine mountaineering and bungee cord jumping. In addition, in a recent survey of 480 economists, healthcare has been voted as the most inefficient sector of the economy. And it has been estimated that approximately $4 trillion are wasted on an annual basis in unnecessary or substandard care. So how do we move forward with this? Let me share with you two quotes by Edward Deming, who's a efficiency expert who was largely responsible for the reconstruction of the Japanese economy after World War II. He observed that every system is perfectly designed to get the results that it gets. He also added, 85% of the reasons for failure are deficiencies in the systems and processes rather than the employee. The role of management or leadership is to change the process rather than badgering the employees to do better. So I think if we want to improve CABG outcomes, we need to improve the system within which CABG is performed. Peter Pronovost, up until very recently, who was a member of the Johns Hopkins University, and his colleagues writing in the Harvard Business Review, described three waves of innovation that are key to patient safety. The first of these involves technical advancements. The second involves standardization of procedures within each institution. And the third is the need to build high reliability organizations. And I think that this has clear applications to coronary artery bypass surgery, and I will discuss them each in turn as they apply to CABG as a potential mode of improvement of perioperative outcomes. So let's begin with technical improvements. I think that we can all agree that cardiac surgeons are passionately committed to technical advancements. One only needs to Google such subjects as perioperative AFib, reoperations, postoperative cardiac arrest, and one can either get anywhere from several thousand to several million hits. Yet despite this prodigious output in terms of cardiac surgical research, as we have seen, the mortality of CABG has not changed significantly. So is it time for us to reconsider how we innovate? And I think, is there some way that we can speed up our innovation process, considering the fact that it takes about 17 years from the time that an innovation is developed to the time that it's implemented into clinical medicine? And I think the answer is absolutely yes. So what are those new ways of innovations? Number one, I think that the inter-center variability of practice offers us natural laboratories for learning as to what is the optimal courses of care. If this is combined with collaborative comparison of outcomes between institutions, with higher performing institutions sharing their best outcomes with lower performing institutions, that will result in improved outcomes. That has been well documented in such states as Michigan, Virginia, and the Northern New England group, where care has been improved significantly by such endeavors. Additionally, new knowledge will be developed by analyzing of large registries, such as the STS database. And in fact, a new program has been launched called the Participant User File Program by the STS, which makes the STS database available to all of its memberships for a very nominal fee and a relatively simple application process that can be found at the address that is above. There are currently 60 projects that have been completed based on this program or in process of being completed, so that everybody in the audience can become an investigator and add to our knowledge base. In addition, the utilization of big data analysis with artificial intelligence and memory learning will give us new ways of innovation. And I think that we are at an inflection point where telehealth and the Internet of Everything will dramatically disrupt the patient-physician relationship. This will become virtual, continuous, patient-centric, and on-demand and in real time. And I think that this will give us an opportunity to potentially send our patients home earlier from the hospital with a telehealth safety net. Another idea that has gotten a lot of play recently is the need for a potential CABG subspecialty within cardiac surgery. This has been articulated by some prominent cardiac surgeons, including Michael Mack, who was our past president of the STS. He writes in a recent article, given the complexities and intricacies of modern coronary revascularization, it may be time to recognize a CABG-specific subspecialty for cardiac surgeons capable of performing state-of-the-art bypass surgery. Similarly, David Adams felt that a CABG specialist would be a way to potentially increasing the penetration of multi-arterial grafting. One element that I think supports this perception is the fact that the average STS surgeon performs on an annual basis 57 isolated CABGs, and respectfully I would submit to you that perhaps that is not enough of a surgical volume to be able to be an expert on all the new developments that are going on. Now, the relationship between surgeon case volumes and outcomes is not clear and debatable, but let me share some information with you that I think will make the case that potentially a CABG specialist is going to improve outcomes. So we published earlier this year an analysis of the comparison of the perioperative outcomes of beta grafting versus single arterial bypass grafting, and also radial artery bypass grafting versus single arterial bypass grafting. And when we looked at the institutions who have relatively little experience with either grafting strategy, we found that both grafting strategies were associated with increased perioperative mortality compared to traditional CABG at those institutions where the multi-arterial bypass grafting volume was less than 5% of the entire CABG volume. Mario Gaudino, in a recent meta-analysis of beta studies of close to 28,000 patients, found that as the familiarity with the procedure increased, both the deep sternal wound infection rate decreased and the long-term mortality decreased. In the ART trial, as we know, there was no difference between beta grafting and single arterial bypass grafting. However, and this was particularly true in surgeons who performed less than 50 beta cases, in those surgeons who performed more than 50 beta cases, there was a significant improvement in long-term survival between beta and CABG. Now, arguably, and honestly, there isn't too much data as to the outcomes of potential CABG specialty, but this report from the University of Maryland group, with their experience with a CABG-specific unit under the leadership of a CABG specialist, is, I think, interesting. And what they have found is after instituting this approach, the beta utilization rate was increased. They noticed decreased transfusion rates. There was decreased ventilation time, decreased stroke rate, and a more important metric that following 2 years of this experience, the mortality rate for the CABG population, entire CABG population, decreased to 1%. So I think that there is some opportunity to improve our outcomes with a CABG specialist. The second wave of innovation described by Peter Pronovost was the need for standardization within institutions. And I think that the current prevailing attitude of surgeons towards standardization is, yes, we'll support it, let's compromise, but we'll do it my way. And I think it's reflective of the prevailing paradigm in cardiac surgery that success in CABG surgery is a mano struggle that is provider rather than institution or system specific. Really, without standardization, any quality improvement efforts are a mission impossible. Standardization leads to predictability with alignment and engagement throughout the entire organization, leading to improved efficiency and allows for continuous quality improvement by correlating outcomes with processes. When it comes to standardization, I think there are a lot of low-hanging fruits for us as CABG surgeons. Both the STS and the European Association for Cardiothoracic Surgery have published clinical practice guidelines that have not been very aggressively adopted into the clinical practice. What is interesting and actually I think calls to action is the fact that in randomized comparative trials of percutaneous interventions versus CABG, the guideline-directed medical therapy was only implemented in 40 to 40% of patients. We must and we can do better, as evidenced by the ART trial under the guidance of Dr. Taggart, where guideline-directed medical therapy was implemented up to 90% of patients. So the third wave of innovation requires the building of high-reliability organizations with alignment between the administrative and the clinical domains. It is important that the clinician be provided with appropriate optimal resources to be able to meet the quality metrics and achieve optimal outcomes. Again, without appropriate resources, regardless of the skill set of the surgeon, winning the quality improvement game is really very difficult, if not impossible. High reliability organizations are characterized by a commitment to leadership, to quality, a commitment to a safety of culture, and dissemination of robust process improvement tools throughout the organization. These organizations are characterized by stakeholder alignment around a well-articulated mission that everybody buys into. Failure for these organizations is simply not an option. Every effort should be made to avoid failure, and if not possible and failure is encountered, it should be a learning opportunity in a safe and non-punitive environment. Again, these organizations are driven by evidence-based practice, accountability, adaptability, and transparency. High reliability organizations also realize that we as human beings make mistakes. And why do we make mistakes? Sorry, trying to get through this. We make mistakes because there's a lot of a reliance on sort of cognitive biases that are sort of baked into our CNS and on the reliance of heuristics as we make decisions. So neurocognitive research has shown that human self-perception as rational beings engage in conscious logical evaluation of data leading to optimal decision-making may actually be a fallacy due to the intrinsic structure and organization of our CNS, our difficulty in understanding probability theory, and our reliance on poorly understood and poorly perceived subconscious elements driving our behavior. We have been characterized as, quote, predictably irrational because we do judge the book by its cover. We reach conclusions based on prior experiences and prejudices and look only for supporting data while ignoring contradictory data. We incorrectly overestimate our own role in our successes. We incorrectly blame external factors in our failures. It's anesthesia's fault, rather than introspectively considering our own roles in our misadventures. We incorrectly perceive patterns and regularities in random processes. So this difficulty in decision-making is also confined, has been documented in the highly functional professionals. Daniel Kahneman, who's a Nobel Prize laureate in economics, writing in Harvard Business Review, stated the following: "The unavoidable conclusion is that professionals often make decisions that deviate significantly from those of their peers, from their own prior decisions, and from rules that they themselves claim to follow." This has been also proven in healthcare, as evidenced by this article in the Annals of Surgery, where the investigators conclude that surgeons varied markedly in both their assessment of risk and benefits of operative and non-operative management. And they conclude that given the same clinical scenario, surgeons' perceptions of treatment risks and benefits vary and are highly predictive of their decisions to operate. So again, a high reliability organization realizes that we have a predilection to making suboptimal decisions, and they proactively put in processes and elements and tools to make sure that we minimize that cognitive biases. So when it comes to coronary surgery, what might be those tools that potentially might minimize cognitive biases? As we had discussed, I heard this morning, a multidisciplinary heart team mitigates cognitive biases of availability and overconfidence and makes sure and assures that the patient is given the most appropriate treatment and an ever increasingly complex choice of therapies. In addition, checklists ensure that what we think is going to happen actually is going to happen, and checklists have been shown to decrease complications in healthcare in general and certainly should be implemented in our day-to-day activities. And finally, the utilization and the reliance on qualitative, objective perioperative risk measures as well as quantitative models to quantify the coronary artery atherosclerotic burden should be used in addition to surgeon experience in allocating the appropriate treatment strategy. So look, high reliability organization building is difficult, but we as surgeons who essentially do all of our work within hospitals should be leaders in this and taking an active and a participating role in trying to develop these organizations. I would like to close with another one of Deming's quotes. "It is not enough to do your best, you must know what to do and then do your best." Thanks for your attention.
Thank you, Tom. That was a great presentation. I think it was really open-minded. I think, however, we have to move to the next presentation because the presidential address is coming. We cannot be late, so we'll ask questions later. Next speaker is Faisal Bakin from Cleveland, and he's discussing what we don't like to discuss, our skeleton in the closet, graft failure, stroke, mediastinitis.
Good morning. Thank you, Mario. Thank you, distinguished panel and the association for the privilege of presenting today. Nobody likes to talk about complications, I guess, except for me. At least that's what Mario thought. So if you look at the Society of Thoracic Surgeons database, we're going to start by talking about deep sternal wound infections. Their incidence is 3 in 1,000. That's pretty low, but they're pretty bad. This is a sinking feeling you get when you go and examine your patient and see this or see some drainage from the sternum that's unstable. And this is typically
what historically has been done, resecting the sternum, doing a radical resection, and maybe even reconstructing with soft tissue flaps and stabilization with plates. And the results historically have been horrible. The mortality for CABG historically is about 20%. If it's a transplant or immunocompromised patient, it's up to 50% plus. So the overall mortality is just over a third. But that was back in the 90s. If you look at this paper from Sweden, where they use a wound vac and carry a more conservative approach like we do at the clinic, basically you go in, do the minimal debridement necessary till you get some bleeding, healthy tissue, and then put a wound vac, and then come back at a later date and either do a delayed definitive primary closure or put a flap if there's a bigger defect, then that usually works. We don't use the C-reactive protein, but some people do. And with that kind of approach, the mortality, at least in their hands, was 0 for the VAC group and 15% in the conventional group. So it's still, I would say, a high morbidity, mortality, immediate outcome for this complication. But what's important is this paper that was published by the Duke group, again back in the 90s, where it shows a remarkable difference in survival, not just them making it out of the hospital, but up to 2 years. There's a marked survival difference between those who have mediastinitis versus no mediastinitis. And this was confirmed by the Cardiothoracic Surgical Trials Network that looked at that in their publication, in their study. 39% were isolated CABGs, which is the population of our interest. And again, there's a significant difference in survival between a patient who gets a mediastinitis versus a patient who doesn't. So short and long-term implications, and nothing about the quality of life, which obviously is going to be impacted really poorly. Now, in terms of risk factors, the network identified predictable things, just such as being on steroids, VAD or transplant, immunocompromised, and peripheral vascular disease. And then when you look at the more comprehensive list using the STS database with millions of patients, I've only highlighted the ones with an odds ratio of greater than 2. So advanced age, so if you're over 80, it's double the risk. Being on dialysis, chronic lung disease, diabetes, and emergency surgery. Again, no surprises. We at the clinic do lots of high-risk cases, so some of our patients end up with a tracheostomy, and I've always wondered whether tracheostomy is a risk factor, and according to this paper, it is, but they couldn't identify a safe time frame between doing the tracheostomy after doing the sternotomy, and that is a subject that perhaps needs further study. Let's move to the issue of single versus bilateral mammary artery, because we talked about multi-arterial grafting, and as I said, the multi-arterial grafting goes back to the Weinberg procedure back in the 60s, where Favaloro actually used bilateral internal mammary arteries to do his Weinberg procedures. But if you look at the Japanese database, and I'd like to congratulate our Japanese colleagues for using the beta in about a third of their cases. The incidence of mediastinitis was 1.6%, and they've used both pedicled and skeletonized approach. They didn't have the data to separate the two, and they found that on-pump versus off-pump didn't make a difference. So that's more of a contemporary series, at least in Japan. And if we go to the ART study, and Dr. Taggart is here, and he talked a little bit about it yesterday, but obviously the complication rate in terms of wound complications are about double if you use pedicled bilateral mammaries versus skeletonized, and also, if you use bilateral internal thoracic artery versus a single internal thoracic artery, and the rate of reconstruction is 3 times the risk if you use bilateral mammaries. However, if you skeletonize, and I'll show you in the next slide, you can overcome that. As to the timing of the sternal wound complications, according to the ART study, they usually occur in the first 2 months. So the STS database tracks you to hospital discharge or 30 days, so you could miss about half or more of those sternal wound complications. So that's the importance now about your technique if you do bilateral internal thoracic arteries. Basically, if you skeletonize, you eliminate that extra risk associated with harvesting both arteries.
And this is a paper by Mario Gaudino that shows that if you're an experienced surgeons that do a larger volume of multi-arterial graftings, including bilateral internal thoracic, then you have better survival, but you also have less deep sternal wound infections. So experience and technique do matter. And this is a nice objective picture for the surgeons that show that actually if you skeletonize on one side versus do a pedicle on the other side, there's a difference in perfusion. So actually the difference is real and can be physiologically explained in terms of the incidence of complications. I was going to show this video, but in the interest of time, we'll skip it because I've showed it before. And if you look at the recent European guidelines, if you are taking bilateral internal thoracic arteries, then it's a class 1 level of evidence B recommendation, and I totally agree with that. There's also other tips in the guidelines to minimize the risk of deep sternal wound infections. They're related to the type of antibiotics. When do you give it? You got to give it within the first, within 60 minutes of making the incision, and also gives us some recommendations about the timings, etc. And I also like to discourage the use of a bone wax. I use vancomycin paste to obtain hemostasis and avoid using bone wax whenever I can. So in summary, when we talk about deep sternal wound infections, it's a horrible complication, but it is rare, it's infrequent, and if you use meticulous technique, you could overcome that complication or minimize its incidence. What about stroke? A dreaded complication, absolutely horrible. Again, it's infrequent, but more frequent than deep sternal wound infection. Its incidence in the most recent analysis of the STS database is 1.3%. And if you look at this paper from Stuart Head, who looked at 11 trials, including 11,000 patients who were randomized into PCIO CABG, the incidence of stroke is higher in CABG compared to PCI. But if you do landmark analysis, if you go beyond the 30 days, then they're identical. So really, it's the perioperative stroke that's the issue. And again, as is the case with deep sternal wound infections, if you get a stroke after CABG or PCI, your mortality increases by fourfold at 5 years. So it has a dramatic longer-term effect beyond just hospital discharge. And this is a large study from the Cleveland Clinic with over 45,000 isolated CABG cases, and it shows that the peak incidence of stroke is really day number 2. Basically, it captures the events that happens intraoperatively or immediately postoperatively, probably related to the hemodynamics in the ICU as well. And the incidence of stroke in isolated CABGs have hovered around the 1.5%, although recently we're more like 1% after isolated CABG. But remember, lots of our patients at the clinic are turned down from elsewhere, and they're higher risk cohort by definition. And again, the theme persists in terms of the long-term impact of having a stroke. Again, if you look at 5 years, you have 4 times the risk of being dead after a CABG if you have a stroke. So try and minimize the incidence of stroke if you can. To identify that risk factors might help you avoid or mitigate them and maybe reduce the incidence in your practice. And in the Cleveland Clinic paper, we've identified the acuteness of the procedure, which makes sense, the age, and cardiovascular morbidity. And what we mean by that is the atherosclerotic burden, basically peripheral vascular disease, carotid disease, etc. Did on-pump versus off-pump make a difference? For the intraoperative stroke, it did, but the hazard ratio was really small. But for the overall risk, it really didn't make a difference between on-pump versus off-pump. And if we look at the STS database, again, I'm just highlighting those with odds ratios greater than 2. The advanced age, cerebrovascular disease, and emergency status are the big ones. Does routine preoperative screening by ultrasound of the carotids make a difference? It's useful in certain scenarios, but it does not help you in any meaningful way, and doing an intervention may not reduce the incidence of stroke. But there are scenarios where it's useful, and I was part of this effort by the STS to identify scenarios where it might be useful, and that was in patients with left main disease, patients with cerebrovascular symptoms, or those with carotid bruit. And if you look at the European guidelines, again, they identify high-risk populations, meaning those who had stroke or TIA within the last 6 months, and the class of recommendation is 1. And then there's other lesser classes for other risk situations. But I agree with the guidelines. You gotta, when you try and avoid a stroke, you want to minimize the manipulation of the aorta. The CT scan can be useful, especially in the elderly patients, and using epi-aortic ultrasound is a very useful modality. This study wasn't done for CABG. It was done for aortic valve replacement by the network, but it did not show any difference based on MRI imaging and volume assessment of the stroke between simple traditional cannulation and those cannulation that use a suction or filter device. So it was actually stopped. But that can actually give us some insight in terms of how we cannulate for CABG patients. I don't think it makes a difference of what kind of cannula or device you use, although for TAVR, this is a different story so far, I think. So in summary, for stroke, it's a horrible complication. Risk factors can be identified, minimize the manipulation of the aorta, and avoid hypotension. Graft failure, the third task of mine to talk about this dreaded complication. There's phases for graft to fail. There's the early thrombosis, intimal hyperplasia, and then the long-term atherosclerosis. This is a nice review by Mayo that you could read. This presentation has not been published by Stephen Ellis. He's one of the interventional guys at the Cleveland Clinic. And this is an important paper. Why? Because it looks at the long-term performance of the second generation in addition to first generation stent. And about half of those patients were either diabetic or pre-diabetic. And look at those results. This is the survival function. But this is the important one. Freedom from target lesion failure. Second generation stents at 10 years, 15.7%. I would say this is better than the historical vein conduit performance. So keep that in mind. This is a nice paper by John Alexander that shows the incidence of graft failure, venous graft failure at different time points. Basically, at 1 month or perioperatively, it's just under 10%. Once you go to 10 years, it's about 40%. And there are ways to try and minimize that, and Dr. Taggart's efforts with the vest is certainly something to look forward to see if that makes a difference in the long term. They've talked yesterday about the no-touch technique. And this is a nice summary again by Mario. Gosh, Mario, you've written all the more important papers in CABG recently. But the winners in terms of the 10-year performance and afterwards are the internal thoracic artery and the radial artery compared to saphenous veins and the gastroeploic. So if you want to minimize the failure of the grafts, in general, use more arterial grafts. And I'm not going to go into the history of arterial grafts, but we celebrated the anniversary of using the mammary after it was first announced to the world in the New England Journal of Medicine and became the gold standard afterwards. And then Dr. Lytle's efforts from the Cleveland Clinic that goes back to the late 90s, early 2000s about the late but the real effect of using bilateral internal thoracic arteries in improving survival. And this is a paper, again, by Mario, that was published in the New England Journal of Medicine that shows that graft patency and clinical outcomes are better when you use radial arteries compared to veins. And this is the study from Buxton that, again, when you look comparing between the reta and the radial artery, there's really no statistically significant difference between the two. So they're probably interchangeable if you choose your target and patient carefully based on the anatomic and physiologic scenarios. And this is the STS guidelines that I was part of, encouraging the use of more arterial grafts. Unfortunately, in the US, unlike Japan or elsewhere in Europe, less than 7% have multi-arterial grafting. And by the way, those pictures should have been skeletonized. I like to give an example. Here's a guy that's 54, diabetic, diffuse coronary artery disease, had previous PCIs, horrible targets, as you can see. So I did a CABG times 5. I did use the beta in him. And he sends me a cake at every year for his anniversary, and just to lighten the atmosphere up a little bit.
Hey, everybody. I'm so thankful that I get a chance to say thank you to everybody on my surgical team because you guys made such a major difference in my life. Since my surgery 2 years ago, I'm a grandpa. I have done a 5K, first one. I did a 10K last year, first one. You guys are awesome. I wished you was all here. I'd give you all a great big hug. I sure do love you guys. Thank you for being the people that you are.
So I'm running out of time. We really care about long-term outcomes. We don't want those grafts to fail. So use more arterial grafts whenever you can. Use the quality control in the OR that Teresa has taught us about extensively, and the guidelines recommend that we use that. Don't leave the OR with any questionable conduit. Antiplatelet therapy, use dual antiplatelet therapy if you're doing off-pump or you're worried about your grafts. That's all I could say at this stage. There's no hard evidence, but I think at this point, I'm going to conclude by saying that those dreaded complications are rare, but they're stressful for the patient and for the surgeon. They're often preventable, and surgical judgment and technique and experience can save the day. Thank you very much.
Great presentation. Let's move quickly to the last speaker, which is Dr. Cooley for Boca Raton. Coronary revascularization is a palliative procedure, importance of optimal medical therapy. Thank you.
Well, good morning, everyone. I really have enjoyed this meeting and this session in particular, and I want to thank the committee for the kind invitation and the honor to present today. I'm going to be talking about coronary revascularization is a palliative procedure and focusing on optimal medical therapy and long-term follow-up. I am a surgeon, so I'll mainly be focusing on medical therapy after CABG. By way of disclosure, I've received some research support from Pfizer and AstraZeneca for atorvastatin and ticagrelor trials, respectively. This is what we do day in and day out. The grand majority of cardiac surgeons perform left internal mammary artery to the LAD and vein grafts to the other targets. Despite increasing focus on arterial conduits at this meeting and other meetings, this is really the bread and butter and is done to the grand majority of CABG operations, especially in North America. And the reason we do it is because it works. Compared to percutaneous coronary intervention, patients undergoing CABG have better outcomes in the context of multivessel coronary artery disease. If we assess the graft function 1 year or several years after surgery, we'd like to see this result, all grafts patent on a CT coronary angiogram, but all too often patients are taken back to the cath lab for a percutaneous coronary intervention for stenosis of vein grafts. Unfortunately, sometimes it's too late, the vein graft is already occluded. The concept that CABG is a palliative treatment is not a new one. It was described as a palliative approach back when Dr. Favallaro was pioneering this technique at the Cleveland Clinic. And in fact, back in the early days, he too advocated for the use of medical therapy after CABG. And the reason that CABG is a palliative operation is because the long-term results are compromised by vein graft disease. The vein graft continues to be the most common conduit used during coronary surgical revascularization, but within 1 year, about 15% are occluded. By 10 years, about 60% are patent, but 40% are occluded or stenotic. And patients are therefore at high risk for subsequent clinical events. I recently had the good fortune to be involved in a guidelines committee with the American Heart Association focusing on secondary prevention after CABG. This guideline was published in Circulation, and guidelines were subsequently published in the European Journal 1 year later. Without going through the guidelines in great detail, I want to highlight some of the elements that they focused on in the guidelines, including 2 key approaches to medical therapy after, for patients with coronary disease, of course, antiplatelet therapy and lipid-lowering therapy, but the guidelines further divulge into the management of hypertension and diabetes, smoking cessation, etc. So I wanted to highlight 2 or 3 elements in this field on secondary prevention. And first, we'll start with antiplatelet therapy. And of course, as we know, aspirin is the gold standard for antiplatelet therapy after CABG. And the reason for this is several randomized controlled trials were performed, placebo-controlled, in the late 1970s and 80s, and they found that graft patency, either at the 1 month time point or at the 1-year time point was significantly improved in those patients that were randomized to aspirin. Subsequently, numerous clinical trials were collated in a meta-analysis that Dr. Fremes performed a number of years ago, looking at 17 clinical trials, and they found that that aspirin strongly influenced graft occlusion. It reduced the incidence of graft occlusion by approximately 40%. The optimal dose appeared to be in the 100 to 325 milligram range, and ideally patients would benefit the most if they received aspirin within 6 hours of the operation. More recently, just a few months ago, another meta-analysis appeared on the subject, this one focusing on preoperative aspirin safety and also its influence on graft occlusion, and the authors found that preoperative aspirin reduced the risk of graft occlusion. Nevertheless, even in the current era, with the contemporary use of aspirin after surgery, the risk of vein graft failure is way too high. In the PREVENT-4 trial, more than 20% of vein grafts were occluded at the 1 to 2 year postoperative angiogram assessment. So clearly we have a need for improvement. So what about newer antiplatelet therapies? Well, we all know about clopidogrel, and it came onto the scene in the early 2000s with the publication of the CURE trial for acute coronary syndrome patients, demonstrating benefits of dual antiplatelet therapy compared to aspirin alone. And we and others shared enthusiasm for the use of clopidogrel after CABG surgery. A number of clinical trials were developed, including one that I was involved in which was called Cascade. It was of modest size, but we found no difference in graft patency whether patients received dual antiplatelet therapy or those that received aspirin alone. A number of other clinical trials were reported around the same era, and for the most part, graft patency was not improved with the use of clopidogrel compared to single antiplatelet therapy with aspirin. This was ultimately summarized in a meta-analysis of 5 randomized controlled trials and 6 observational studies. They did have enough power to see that vein graft occlusion was reduced with dual antiplatelet therapy, and this was significant, but it was mainly in those patients undergoing off-pump surgery. In the on-pump surgery subgroup, there was really no benefit to dual antiplatelet therapy. Of course, there's newer antiplatelet therapy medicines on the market, prasugrel and ticagrelor. Ticagrelor was found to be beneficial compared to clopidogrel in patients with acute coronary syndrome in the PLATO study. In a sub-study of PLATO, focusing on the 1,200 patients that ultimately underwent CABG, cardiovascular mortality was improved for those patients that were randomized to ticagrelor compared to clopidogrel. And as such, there's been some enthusiasm of late for using ticagrelor after CABG to improve graft patency. To date, there have been 2 clinical trials that have been published on the subject. One was a small study from Vancouver involving approximately 70 patients. Patients were randomized to dual antiplatelet therapy, ticagrelor and aspirin, or aspirin alone. They assessed graft patency at the 3-month time point, and they found that ticagrelor plus aspirin reduced the incidence of graft occlusion or stenosis more than 50%. However, bleeding was much higher in those patients that were randomized to ticagrelor. More recently, this trial from China was published in the Journal of American Medical Association, and a much larger trial, they randomized patients to receive either ticagrelor and aspirin, ticagrelor alone, or aspirin alone after CABG surgery, and they assessed graft patency at the 1-year time point. They found that graft patency was 88.7% in the dual antiplatelet therapy group compared to 76% in the aspirin group, and this difference was highly significant. Now, while the results were striking, should be cautioned in terms of the interpretation because there was no blinding and there was no placebo control in this study. And most importantly, the majority of patients underwent off-pump surgery, 76% in this study, and therefore the results may not necessarily be generalizable to the contemporary use of CABG with bypass. And finally, I think it's important to note that they chose to use aspirin at a dose of 100 milligrams in this study, and I think that's insufficient for use as a single antiplatelet therapy agent after CABG, and perhaps it biased the results in favor of CABG. We too are conducting a ticagrelor graft patency trial after CABG. we're randomizing patients to receive either ticagrelor or aspirin twice a day, starting within 5 days after surgery in our Taggart trial, which is being performed in Florida and in Ottawa, Canada. We're close to finishing recruitment, and hopefully we'll have CT coronary angiogram patency results in the near future. I want to shift focus now and talk about one of the other mainstays of secondary prevention after CABG surgery, and this, of course, is lipid-lowering therapy. And the field of secondary prevention after CABG really took a major step forward with the publication of the post-CABG trial in 1997 in the New England Journal. The investigators enrolled about 1,300 patients who had undergone CABG about 1 to 11 years previously, and they were randomized to what is conventionally, in the contemporary area, known as medium intensity statin therapy, lovastatin 40, or low-dose statin therapy, lovastatin 5 milligrams daily. And after 4 years, the patients that received the medium dose, lovastatin 40, it reduced LDL levels significantly, lowered the incidence of vein graft occlusion, lowered the risk of MACE, and also the need for revascularization. And with striking results over time, more and more investigators, more and more surgeons are applying statin therapy early after surgery since the publication of the post-CABG trial and subsequent guidelines thereafter. But of course, in today's environment, we're more often talking about intensive statin therapy using high doses, such as atorvastatin 80 or rosuvastatin 20. And this is based on numerous clinical trials in patients with acute coronary syndrome or stable coronary disease, where high-dose, high-intensity statin therapy was associated with improved outcomes. We ultimately looked at the impact of lipid levels on graft patency after CABG, and in a post-hoc analysis of our clopidogrel trial, Cascade, we found that patients that had LDL levels more than 100 at the 1-year time point had significantly lower graft patency. Ultimately, we performed a clinical trial called EACTS, whereby we randomized patients undergoing CABG to either medium dose, atorvastatin 10 milligrams, or high dose, atorvastatin 80 milligrams, starting within a few days after surgery with CT coronary angiograms at the 1-year time point. And we recently had the good fortune of presenting the results of the EACTS trial at the American Association of Thoracic Surgery meeting just a few months ago in San Diego. We found that patients that were randomized to atorvastatin 80 milligrams had a 26% significant reduction in LDL levels after surgery. And all endpoints, vein graft endpoints, were improved in the patients that received 80 milligrams. This was not significant when we looked at specific vein graft endpoints, vein graft occlusion or stenosis or occlusion combined. But when we looked at the patient level, we found there was a trend towards significance in terms of lower risk of occlusion or stenosis at the patient level for those that received atorvastatin 80 milligrams daily. And these results are currently in press in the Journal of Thoracic and Cardiovascular Surgery. Finally, I just want to touch on the importance of long-term follow-up and compliance with medical therapy. There's been a number of studies that have been published recently on this subject, one with New York group, Kurlansky, and Dr. Michael Mack. They compared percutaneous coronary intervention patients and CABG patients and evaluated the impact of medical therapy on the outcomes. And what they found was that for both PCI and CABG, the compliance with optimal medical therapy was a more powerful predictor of cardiac events than the choice of therapy, PCI or CABG, in itself. This figure summarizes the results of that study, and on the right you can see the patients that received optimal medical therapy, either CABG or PCI, had far improved outcomes compared to those patients on the left who did not receive optimal medical therapy. And finally, a recent study, I think this was referred to in previous talks from the Journal of American College of Cardiology, by contemporary clinical trialists who summarized data from clinical trials evaluating CABG or PCI. And they found, exploring the compliance with goal-directed medical therapy, they found it remains suboptimal and is significantly lower after CABG compared to PCI. What I found the most interesting, though, was the meta-regression that they performed evaluating the influence of compliance on outcomes. And the authors found that as the difference in compliance favored PCI, the superiority of CABG, and in terms of clinical outcomes, actually decreased. So in summary, coronary bypass surgery is the most effective therapy for patients with multivessel coronary disease, but CABG surgery is and remains a palliative procedure. Secondary preventive therapies have a critical role both before and after CABG surgery, and compliance with medical therapy influences their long-term outcomes. Thank you very much for your attention.
Thanks, Dr. Cooley. Great presentation. I think we need to end the session here. The presidential address is coming. So thanks everybody for attending, and stay here for the presidential address. Thank you.